and today's topic is epilepsy. So the first speaker today is Dr. Harsh Oza from Bombay Hospital, and the mentor is Dr. Lal Kaka. So over to Dr. Lal Kaka and Harsh.
Can we have only those two videos on, please?
Yeah. Let's request everyone to shut off their videos and their sounds.
Harsh and Jimmy.
Yes, sir.
Sir, good morning.
Keep your video on.
Yes, sir.
Put my video on.
Yes.
Action.
We are switching off our videos.
Sure.
Hello, sir. We are in live. Good to go, sir.
Kindly begin.
Okay. Thank you, sir. Very good morning to all consultants and all my colleagues. I'm, as Khadilkar sir told, I'm Dr. Harsh Oza, DM Neurology resident from Bombay Hospital. So today's talk, as you all know, is regarding epilepsy. So my first talk is regarding the epilepsy overview and revised classification of seizures and epilepsy. The topic has been written in Continuum by Dr. Alison M. Peck, who is the professor of neurology in Columbia University, New York, and she has special interest in epilepsy. All her publications and presentations are mainly related to this topic. So what I'm going to talk about, so outline of my talk today. So I'll go briefly through some definitions of seizure, epilepsy, then I'll move on to seizure classification, old versus new, and the third part will be old versus new epilepsy classification, then some salient features which I would like to throw some light upon, otherwise some routine features you already know, and then last topic is the take home message. So I'll begin with the definitions. So as we all know, seizure and epilepsy are two different things, and their definition also differs. In 2005, we have got the definition of seizure, which is mainly electrophysiological based. So transient occurrence of signs and or symptoms due to abnormal excessive or synchronous neuronal activity in the brain, which means there would be some abnormal excessive or synchronous hyperactivity of the neuronal cells, which lead to some clinical manifestation, and hence epilepsy, which is defined in 2014. So when an individual has an epileptic seizure and his or her brain demonstrates a pathologic and enduring tendency to have recurrent seizures. So I'll go through the definition more in detail in the next slide, but in general, epilepsy means that the patient or that person has again and again throwing some recurrent seizure is his tendency. So enduring tendency of his brain to throw some recurrent seizure is the main thing. How we define epilepsy nowadays, and there are mainly three definitions. First, we all know at least two unprovoked seizure or reflex seizure more than 24 hours apart. So why they have taken 24 hours apart? So that means that the chances of recurrent seizures later during some more preceding years would be high. So if they throw two recurrent seizures within few hours, there may be some underlying cause which is treatable, and hence we do not consider that as epilepsy. When the seizures are more than 24 hours apart, the confidence interval by which we can say that the patient has likelihood of throwing few more episodes of his seizure increases. Second definition, which is the slightly newest one, is single unprovoked seizure or reflex seizure. Now they say that even single unprovoked seizure or reflex seizure may be considered as an epilepsy when we know that that person has a high probability, which is at least 60% of throwing another season in the next 10 years. Now this, why they have taken 60%? So that is based on statistical analysis of prospective trials in which they evaluated patients for a few years, and in which they found that when the patient has likelihood of throwing another seizure, the confidence interval is taken into account, which should be at least 60% to 100%, which means that minimum 60% should be our probability by which we can say confidently that this particular patient will throw some more seizure in the next 10 years. Now those detailed methods they have not given in the chapter or other trials. And the third thing is presence of diagnostic epilepsy syndrome. So when we diagnose an epilepsy syndrome, it automatically qualifies for the definition of epilepsy also. What is this diagnosis of epilepsy syndrome? Means we already know that there are particular types of epilepsy syndrome such as Lennox-Gastaut, Dew's, Dravet syndrome. All this syndrome means that that person has a particular type or types of seizures, and they have corresponding MRI and EEG features, which presents as a cluster of features and which define as epilepsy syndrome. Now going through the seizure classification and what are the news and debatable issues regarding the previous versus new classification. So we already know this international classification of seizure in 1981, which we were used to keep in mind in clinical practice till now. So partial seizure, generalized seizure, and unclassifiable seizure. I won't go in detail. We already know the detailed types of the seizure, but the main issue was they defined as partial word, partial seizure, then the generalized seizure, and the unclassifiable. Main areas by which they defined this was the onset of seizure. So if the onset is partial, they defined is a partial seizure. So of course it starts in one part of the cerebral hemisphere and usually remains in that part only, unless secondary generalized, in which it may proceed to the contralateral hemisphere also. In generalized seizure, the onset is usually generalized. So usually it starts with either bilateral tonic clonic or absence or atonic or myoclonic, the types you already know. The underlying pathophysiology is that the electrical disturbance inside the brain, of course, usually starts in some part of the brain, but then rapidly proceeds to the contralateral, hence more or less symmetrical or rather huge involvement of bilateral cerebral hemisphere. Now, there are some debatable issues regarding this 1981 seizure classification. Which are they? So some seizure types such as tonic seizure or epileptic spasm, they may have either focal or generalized onset. By this we mean to say that the onset, even if we know, may have either focal or generalized onset, hence to classify it in either partial or generalized sometimes becomes difficult. Lack of knowledge about onset. So suppose a patient comes to us with some unknown onset. So relatives usually say that they did not notice the onset, but when they saw the patient, he was either having urinary incontinence or some abnormal movement, but the onset was not very clear. So this 1981 seizure classification says that when the onset is not known, so we classify it as unclassifiable because we don't know the onset, hence cannot be said as partial versus generalized. Now this has been corrected. Some terms do not have universal acceptance, such as psychic seizure, partial, simple, complex, dyscognitive. So these were not having universal acceptance among the groups of epileptologists. Hence, these are being removed in the newer classification. And some important seizure types are not included in the 1981. So as the days progress, we were evolving and using the newer epilepsy classification and seizure classification into routine practice. So I'll move on to the newer classification now. So what are the difference between 1981 and 2017 classification? 1981, as I already described, we use partial, generalized, and the last one was unknown onset. Based on the onset, the 2017 seizure classification says that partial word should not be used. It is rather focal in onset and may or may not progress to the bilateral hemisphere involvement. Then simple and complex words were used based on consciousness of the patient and memory of the event. Now we say that focal onset can be with or without impaired awareness, hence simple and complex partial seizure should not be used. The third one is secondary generalization, which you already know that partial seizure may secondarily generalize based on electrophysiological features. The newer definition says that focal onset to bilateral tonic-clonic seizure is a more appropriate word. When we come to the generalized seizure type, we already know these types: tonic, clonic, atonic, myoclonic, and absence. In 2017, they have defined as generalized onset with motor versus non-motor predominant features. So in motor, I'll describe those features more in detail in the next slide. And the third one which they have classified is the unknown onset. Hence, the onset may be unknown, but still the features can be defined as either motor versus non-motor predominantly. And the last one in which we also don't know whether the features are motor or non-motor. When this can happen for practical purpose is that the patient witness the relatives will witness the last part of the seizure when they saw the patient unconscious with some urinary incontinence or tongue bite, but that's it. Nothing else of the semiology was. We don't know the onset, we don't know the semiology and the pattern of evolution, then we classified it as unclassified. So the newer classification has been shifted of seizure from focal onset, generalized onset, unknown onset, and unclassified. Now going more in detail of the 2017 seizure expanded version. So we already described focal onset, generalized onset, unknown onset, and if we don't know anything, unclassified. Regarding focal onset, three things to be asked: whether the patient was aware or not. I'll describe what is awareness in focal onset slightly later. The second part is the predominant features, whether it was motor or non-motor. In motor, we already know it can be automatism, atonic, clonic, epileptic spasm, hyperkinetic, myoclonic, tonic. In non-motor onset, these are more important: autonomic features or behavioral arrest or cognitive features or emotional features or only sensory part. I'll describe this later. And focal to bilateral tonic-clonic seizure. So in focal onset, we need to ask the patient specifically regarding relatives for the awareness for the predominant semiology of the feature, whether it was motor or non-motor, and whether it has involved bilateral parts. So bilateral tonic-clonic has been there or not. So this was focal onset. In generalized onset, we define it as motor versus non-motor, mainly based on the predominant semiology. Unknown onset, we don't know the onset, still we can define whether the predominant involvement was motor or non-motor. And last, if we can't define all these parts, unclassified. So this is the newer seizure classification that has been adopted in 2017 by International League Against Epilepsy. We move forward. So this is the example how it has changed. Suppose a woman, there is a patient who comes to the casualty. A woman awakens to find her husband having a seizure in the bed, but she did not notice the onset. But she is able to describe that her husband had bilateral stiffening followed by bilateral shaking. We did the EEG and MRI, which turned out to be normal. This seizure was classified, now it is been classified as onset unknown tonic-clonic. So we don't know the onset, but we know the semiology that it has been going towards bilateral tonic-clonic involvement. Now, if we classify these based on old classification, hence the onset was not known, so we will classify it as unclassified, which is not correct. Hence, the newer classification say unknown onset tonic-clonic seizure. There is no supplementary information to determine if the onset was focal or generalized. In the old classification, we used to describe it as unclassifiable. So this is the main difference in seizure classification. Now we move on to the epilepsy classification. In old epilepsy classification, we used to describe epilepsy as either idiopathic, symptomatic, or cryptogenic. Idiopathic means there was no underlying cause except a possible hereditary or genetic predisposition may be there. Symptomatic, we know the cause, which may be anything, structural, genetic, metabolic, immune, infectious, anything, but we used to keep it as a cluster of symptomatic cause. Main aspect was idiopathic, we don't know except hereditary may be possible. Symptomatic, we know the cause. And cryptogenic is epilepsy likely to be symptomatic, hence we know the cause, but we are not able to identify. So it appears that the epilepsy is likely to be due to some underlying cause, but we are not able to identify it. Then we used to define it as cryptogenic, but this is old. Now we have changed to generalize the newer epilepsy classification is again based on the seizure classification only. So in seizure, we used to define it based on onset, generalized, focal, unknown onset, and unclassifiable. Now again in new, generalized epilepsy, focal epilepsy, sorry, combined epilepsy, and unknown. Generalized epilepsy means one or more generalized seizure types with supportive EEG feature. Focal epilepsy means one or more focal seizure types with supportive EEG. The main difference between generalized and focal versus combined is that combined can have both seizure types, focal as well as generalized seizure types. Examples of such epilepsy syndromes are Dravet syndrome and Lennox-Gastaut, in which we may find both seizure types, generalized as well as focal. Hence, we cannot define, though it is epilepsy, we know that it is an epilepsy syndrome. According to the newer epilepsy classification, it would be combined epilepsy. And if we can't fit in any one of these groups, it would be unknown epilepsy. Now, this is the main slide of the whole talk. Newer epilepsy classification defines how we should approach a patient when we practically see a patient who is presenting to us with seizure. So the approach has 5 steps. First, we define whether it is a true seizure or not. Once we are sure it is a seizure, we move forward to the types of the seizure. Either it was focal or generalized, or we don't know the onset. Then we move on to the epilepsy classification. So from seizure types, we move on to the second part of approach, which is epilepsy type. So once we have defined that it is seizure, based on the history, 2 or more seizures, or the epilepsy syndrome, we define it whether the seizure types were focal, hence focal epilepsy, seizure types were more generalized, hence generalized epilepsy. Combined generalized and focal seizure types may be based on history, or we don't know any of these, then unknown epilepsy, but epilepsy is there. Then third one, whether the patient fits in any epilepsy syndrome based on a supportive MRI and EEG feature, which may provide a clue to the cluster of features favoring a particular type of epilepsy. Then the fourth part, which is the most important and most emphasized in the newer classification, is the etiology of epilepsy or seizure. Now they say that rather than classifying it as we know the cause or we don't know the cause, we have moved on. So we should identify and try as much effort as we can put to find out the underlying etiology, as it has significant impact on prognosis as well as management part. So we should try to look for the following etiology. The etiology can be either genetic, structural, metabolic, immune, infectious, or unknown. Sometimes we may not be able to find the etiology, then unknown. And the last part is the comorbidity. So for example, if we have identified the patient as having focal epilepsy and we plan to start him on carbamazepine, but the comorbidities are also important. Suppose the patient has TB and he is on rifampicin, then drug interaction should be taken into account. If the patient has significant occupational hazards such as driving or any other such occupation in which he should be alert, so then sedative aspect of the drug should be taken into account. Hence comorbidity is also an important part to be taken care in the management. So this is the 5 steps approach, and plus more importance to the etiology has been given in the newer classification. I move forward. So now we go to the difference what we found in epilepsy of old versus epilepsy of new classification. So suppose if a patient has channelopathies or GLUT1 deficiency as the underlying cause of seizure and epilepsy, the old epilepsy classification would identify as idiopathic because the cause is either we don't know or it may be genetic, hence idiopathic. But the newer classification says that we should try and put as maximum effort as we can to find out the underlying etiology, which is genetic, and hence the newer classification does not say that it is idiopathic, it is genetic epilepsy or seizure. Second part is tuberous sclerosis or cortical malformation such as dysplasia or MTS. So older days we also tried to find the cause, and if the cortical dysplasia was there, we would I classify that epilepsy as symptomatic because we know the cause. The newer classification says that this is either structural or metabolic, hence we define the newer epilepsy as structural or metabolic epilepsy. And for third example, if we don't know the cause, it was identified as cryptogenic because we thought that the cause is there but we are not able to identify, hence more simplified term is unknown. There may be cause but we don't know the epilepsy classification cause. So these are the main differences based on epilepsy classification in the newer one. Now we move on to some salient features. I won't go in detail regarding every subtypes of seizure as we already know, but some of the aspects are important to discuss, such as awareness in focal seizure. The first point that we should ask in focal seizure is awareness, then motor versus non-motor, and the third is whether it is secondary generalizing or not. So what is awareness? Suppose a person is having a focal seizure, so his or her awareness is determined by whether the person knows who they are and what is going on in his or her surroundings during the seizure. It does not refer to the awareness of the seizure occurring. What we mean by this is, for example, when we put a patient on video EG for focal versus generalized seizure or any other part, we should specifically tell relatives or paramedical staff or whenever we are present to suppose show a pen and let the patient say what it is. And after seizure, we ask again. So two parts are considered. One is awareness and one is memory of the event. Awareness is whether during the event patient is able to say yes, this is a pen, or yes, I am in Bombay hospital or this hospital and I know who is there in the surroundings. So that means that the patient is aware, and hence the classification would be focal seizure without impaired awareness. And if after the event patient is able to say that yes, you showed me the pen, yes, you asked me this or these questions, that means he has the memory of the event also, which is also an important part to be considered during focal seizure classification. Now, motor classification of seizure we already know. So I'll move.
Harsh,
Yes, sir.
very simply put, is awareness of the environment and
Yes, sir.
awareness of the seizure.
Okay, sir. Yes, sir.
This is what you're trying to say.
Yes, sir.
All right.
Yes, sir.
So put it simply,
Yes,
that
sir.
if there's awareness of the environment
Environment.
or awareness of the seizure itself.
Yes, sir. Yes, sir.
And usually both will go in tandem.
Yes, sir.
Okay.
Yes, sir.
Fine.
Thank you. So now we move on to the non-motor manifestations of the focal seizure. So
One more comment that I'd like to make here
Yes,
is
sir.
that nowadays the word aura is gone
Okay, sir.
because the aura was awareness.
Yes, sir.
So now you all are calling it awareness and you're not using the word aura.
Yes, sir.
Okay,
Yes, sir.
thanks.
Thank you,
Proceed.
sir. Now, non-motor manifestation. Autonomic seizure would have significant change in all autonomic features such as heart rate, BP, sweating, skin color, or GI symptoms. So this would be the predominant part of the seizure, hence autonomic seizure. In non-motor behavioral arrest, cessation of movement is the dominant part, includes a blank stare. So these are the predominant feature of focal seizure with non-motor behavioral arrest. In cognitive seizure, there would be either deja vu or jamais vu, as we already know, feeling of unfamiliarity versus familiarity, and hallucination as the main aspect of the cognitive seizure. Emotional non-motor focal seizure would have significant anxiety, fear, features of pleasure or dread. So these are emotional non-motor focal seizure. And in sensory, significant sensation change such as taste, smell, hearing, or vision. So these are non-motor focal seizures. Now, generalized seizure. Again, motor versus non-motor. Non-motor is mainly absence. In motor, two newer types have been included. One is myoclonic, tonic-clonic, which means the seizure begins with some myoclonic, jerky, irregular movement, then quickly followed by tonic-clonic part. Usually, we see this type of seizure in JME. So, juvenile myoclonic epilepsy is a type of myoclonic tonic-clonic seizure. Another is myoclonic atonic. So again, starts with some irregular jerky movement, which is myoclonic, followed by loss of tone on both the sides. Usually, we found this in DOS syndrome. So these are the newer types of generalized seizure. Uh, Generalized non-motor or absence seizure. So these are usually typical versus atypical. Newer part is myoclonic absence and eyelid myoclonia. First, we all know typical absence seizure would have abrupt onset, abrupt recovery, 3 hertz generalized spike and wave pattern, which is known to all. Atypical absence seizure would have a relatively slower onset, prolonged recovery time, and more pronounced changes in the tone. Myoclonic absence would again begin with some irregular jerky movement followed by an absence seizure. Eyelid myoclona. So myoclonic movement mainly limited to the eyelids. Jerky movement of the eyelids and upward deviation of the eyes precipitated by light and closure of the eyes. Eyelid myoclonia with absence seizure is usually seen in G1 syndrome. So these are the few newer types of non-motor generalized seizure. Now, one more class definition. When we consider epilepsy resolved, so we are done with the seizure classification, epilepsy classification, what was old, now what we know as new and changes in the epilepsy and seizure, and now what is resolved epilepsy. Epilepsy is considered resolved. There are two aspects. One is regarding syndrome. So when a patient with an age-dependent epilepsy syndrome is older than that particular age in which the syndrome was active. So suppose a particular patient has an X or Y type of epilepsy syndrome, which we know that occurs in the first or second decade. He had multiple seizure types, he was on multiple medication, and now he has passed that age, and now he is in 40s or 30s with no significant seizure or other manifestation since long. So we consider that he has passed the age of the particular epilepsy syndrome, hence we considered that as resolved. Or when a patient has been seizure free for 10 or more years, or has been off all anti-epileptic drugs for 5 or more years, then we consider that as resolved epilepsy. Now the last slide, summary of the changes. What have we found? That there has been newer inclusion in the latest classification. So we have discussed it already. We'll go through the brief. Seizure based on onset in older classification was either focal or generalized, or to be more precise, partial or generalized. Newer classification says that seizure based on onset can be either focal, generalized, or of unknown onset but still classifiable. Second part is partial seizures were classified as simple or complex based on consciousness or event of memory. Now we say that focal seizures are now classified based on awareness, either with or without impaired awareness. Third part is partial seizure with secondary generalization. This term has been abolished. We don't use this. The newer classification says it is a manifestation of focal seizure with bilateral tonic-clonic involvement. Fourth, now this is another thing. Epilepsy is a disorder, and now we say that epilepsy is a disease. This is just to emphasize more that epilepsy has a significant burden on the patient, relatives, as well as healthcare structure, and disorder seems to be a slightly relatively lesser burdenful or impactful word, whether disease considers that epilepsy in itself is a disease, and hence specific management aspect and prognosis should be discussed. So take home message: approach in practical scenario is important. You classify seizure and epilepsy based on seizure type, then epilepsy type, then epilepsy syndrome. Then most important part which they want to emphasize is try and go into the details of the etiology, plus comorbidity should be taken into account for management. Etiology has significant value, as we already discussed, and focal and generalized seizure or epilepsy are not mutually exclusive. We have seen the combined type as newer existence also. So there can be focal plus generalized seizure type in a single patient, which will be defined as combined epilepsy. Thank you, sir.
Excellent, Harsh. You were very clear and crisp. Thank you very much. So now we invite comments from the mentor, Dr. Lalkaka, before we open it to the house. And I have one small comment to make after Jimmy speaks.
No, I think here we can reverse the role of mentor and this thing, because I think I learned so much from his talk. I have nothing more to add. I think it was extremely crisp, very nice, riveting all the time. And I think well done, Harsh.
Yeah.
Can I make a comment, please?
Sir, yes, sir. After you, I want to make one, sir. Yeah.
Yeah.
Yes, sir, please.
I would love to show Harsh and all a slide when I was talking about epilepsy in the late 80s, 90s, you know, to general practitioners and trying to make it a simple thing. And I used to show a focal onset with the spread of the focus to the neighboring area of the hemisphere. And we would call it focal epilepsy. Then we were told by the younger generation to call it partial epilepsy. And now I would say the younger generation, I would consider it something like a son. And now my grandchildren are telling me again, go back to partial epilepsy.
Yeah.
You know?
That just shows old is gold.
I think these people who are involved in classification have nothing better to do. So they have to make something new and changes.
They have to earn a living.
Yeah. But I'm glad it has become relatively more clinically orientated and slightly more simple. Okay?
Yeah.
No, sir.
Actually,
whenever there is a new classification in medicine or a new definition in medicine, there is always a reason behind the madness. Now let's take stroke. When I was an undergraduate under you, you taught us that TIA is transient ischemic infarction. Now that has no meaning, because 24 hours after a deficit, my going and seeing the patient and calling it a stroke has no meaning today. So therefore, now TIA has become threatened ischemic infarction. The same thing in epilepsy. The key to epilepsy management, and which you're going to come to Arjun's talk now, 2 talks from here, is early identification of patients who benefit with surgery. And in that context, the new classification has got a very deep meaning behind it. So we can't correlate.
What percentage, sorry, Ashok, what percentage of patients go in for surgery for epilepsy?
What is
the percentage of patients?
Arjun, are you there?
Hold on.
1%. 1% of patients who deserve surgery get operated. I think Arjun is there.
What is
the figures with him?
Please tell me whether the percentage of patients who require surgery, even do not get it, it's another question altogether, but who require surgery for epilepsy, are they the majority of patients or are they the minority of patients? Therefore, you are making a classification for minority.
Hyper minority, and that is the point Arjun is going to come out with.
But then you are making a newer classification to identify a minority of patients when the majority of patients go under.
It is implicated that we neurologists are not aggressive.
Come on, Ashok, come on.
Let's see, Arjun, you're there.
I think it's a very, very interesting, very interesting discussion. I was going to say something on the similar lines, that every few years we come out with something new.
Correct.
And then we look back at what was old. Some of the things you feel, okay, how did we ever do it in the first place? They look so crude. And there are some others in the new that don't make sense. So I think it just goes on moving from one time to another in an effort, of course, to help people better. But here, I think the role, a little emphasis towards surgery is there in this classification. The second comment is that if we believe that the essence of advanced knowledge is simplicity, I don't know where we are going. I think we just seem to be changing from one complex to another complex. And are we really advancing or not?
No.
I don't know. And thirdly, some of the terms that Harsh mentioned, I have some difficulty in understanding them clearly. Like, what is resolved epilepsy?
For a family whose child has become seizure-free after surgery, we have advanced.
Yeah, and that's because of our MRI and
That is less
localization.
Than 1%.
And
that is even less than 1%. And I agree.
Yeah. And lastly, in terms like resolved epilepsy, I don't fully understand them. I mean, what's resolution? In the doctor's mind, the puzzle is solved. Is the patient cured? I mean, I don't know what's resolution of epilepsy.
The answer comes after 10 years.
Correct.
Of seizure free.
I mean, if we were to
in
believe
10 years, you cannot use the word resolve.
Correct.
You'll have to use the word control.
Yeah.
If we were to believe Gowers, once an epileptic, always an epileptic.
Well, I think from Gavar's time to now, the investigations and everything else have improved so much that our understanding of epilepsy has also improved.
Absolutely.
You know, and therefore these newer classification, in my opinion, have rather simplified everything.
And I think that's very nice because it's for the garden
improvement.
variety neurologist. Yeah.
It's an improvement. It's an improvement on the older classification.
Correct.
Where even a simple non-epileptic, what do you call it, epileptologist can understand the classification.
Yeah.
I think it's a good thing that.
Also, why is so much stress on motor? Yes, Dr. Khan. Yeah.
I think it's a very good.
Sir, we can't hear you.
I think it's a very good thing. Can you hear me now?
Yeah.
Yes.
It's a very good thing that the partial and has been applied, because partial was a very confusing term and confusing to teach also. So focal is focal. That's good. The other thing is that I just want to say that I feel that the definition of awareness and to use it in classification is going to be confusing and difficult.
Yes.
Clinically, that's what I think. I think that awareness, I'm not sure, really be part of a classification because there are so many gray areas. Would others like to?
Yeah, exactly. I think what awareness is itself, we are not very sure. Is it us in the environment? It is us ourselves inside. We don't know what's awareness. So that's going to be a problem. Yeah. So do we move on to the second talk now?
Yes.
If there are no other comments, second talk. Evaluation of seizure etiology, Dr. Reshik Korokkaran from Jaslok and Azad has guided him. Reshik, please.
Yes, sir. Good morning, everyone. I'll just share the screen.
Reshik, you have to become visible.
One second, sir.
Reshik and Azad have to become visible. Azad is. Yeah.
What about Azad?
I'm here, sir.
Good morning, everyone. Today I'm Dr. Reshik Korokaran from Jaslok Hospital, second year DMB resident. So today we are going to discuss about evaluation of seizure etiology. Starting with introduction, 1 of 10 people approximately throughout their lives will present an isolated seizures, and about 40 to 50% of the first seizures correspond to acute symptomatic seizures. Therefore, it is essential to recognize the cause of a first seizure and identifying the etiology of epilepsy. A systemic approach to patients who present with a first seizure helps to distinguish between an acute symptomatic seizure, provoked or unprovoked seizure, and potential mimickers. So this is a chart showing epilepsy evaluation. So first step which we need to do is to find out the type of the epilepsy, whether it's a focal one or a generalized one. In the focal one, determine if whether it is a frontal, temporal, or a parieto-occipital onset. Then we need to discuss about the seizure type, which involves the seizure description, EEG finding, which could be interictal or ictal, and then the frequency, other factors like triggering factors, timing, awareness of events, and risk factors. The most important part is finding out the etiology of the seizure, that is structural, metabolic, genetic, infectious, immune, and unknown, and also to evaluate about the associated comorbidities. Approach to a patient with new onset seizure. First step is to find out the risk factors for provoked seizures, such as sleep deprivation, alcohol, or illicit drug exposure. 20% of cases may reveal a history of absence, myoclonic, or subtle focal aware seizures that were previously unrecognized as signifying a new onset epilepsy syndrome. A detailed history and examination will help us to detect an acute symptomatic seizure, which may present as persistent focal deficit, prolonged altered consciousness, or fever. So what we need to do in a case of acute symptomatic seizure is an urgent workup, brain imaging, blood workup, lumbar puncture study. Also, we need to assess injuries from a convulsive seizure that could be tongue bites, lacerations, back pain from a compression fracture, or shoulder pain from a subluxation. So approach to a patient with first unprovoked seizure with an epileptogenic structural abnormality on brain imaging or an intractile epileptiform activity on EEG has a greater than 60% risk of recurrence. These patients are considered as having epilepsy, and these patients also benefit from anti-epileptic medication. So these patients also include first nocturnal convulsions as well. Patient with first provoked seizure, there is no need to treat. They need counseling about their lifestyle modification and also, if necessary, refer for drug and or alcohol rehabilitation. Acute symptomatic seizures. It is treated with temporary anti-epileptic coverage for a variable amount of time, and the duration depends on resolving of underlying process and correction of an acute trigger. Acute brain insults can have a risk of leading to late seizures in up to 20% of patients. They do not warrant prolonged long-term seizure prophylaxis, even if the injury was associated with early seizures or status. Penetrating head trauma and herpes encephalitis are considered exceptions as they have 50% risk of developing epilepsy. Brain imaging in first seizure. So, urgent imaging is needed when a patient presents with a neurological deficit, a persistent altered mental status, recent trauma, or prolonged headache. CT scan and standard MRI protocols often fail to detect the lesions associated with chronic epilepsy. Hence, MRI should be performed using an epilepsy-specific protocol. The use of MR epilepsy protocol increases the sensitivity in detecting often subtle abnormalities, and they may be amenable to epilepsy surgery. EEG in first seizures. So an urgent EEG is needed in patients who do not have a timely recovery after a seizure, who have fluctuating mental status changes, and showing a neurological deficit that is not explained by the imaging findings. A routine EEG is sufficient to detect subclinical seizure activity. It detects only 1/4 of patients with subclinical seizures in first 30 minutes. And subclinical seizures 90% of subclinical seizures can be detected if the EEG is continuous around for 24 to 36 hours. EEG recording after a new onset seizure can show intractile epileptiform activity. It helps to determine the potential seizure type and recurrence risk after first event. In new onset seizures, 29% will have epileptiform activities. Epileptiform abnormalities are more frequently seen in patients with 24 to 48 hours of a new onset seizures. And patients with the provoked seizures needs to undergo EEG and a brain imaging study as they are found to have a remote structural abnormality or an EEG indicating a predisposition for generalized seizures. This is a flowchart which shows a basic approach towards acute symptomatic seizures, provoked seizures and unprovoked seizures, and their related workup. Coming to epilepsy evaluation.
I think you must mention that it's in page 325 of the chapter.
Yes, sir. Yes, sir. Now coming to epilepsy evaluation. To describe the seizure type, is there any specific epilepsy syndrome, focal seizures associated with aura or loss of awareness, patient or family may have already recorded an event on video to identify whether there is a trigger, non-adherence to medication, or an incomplete medication response. This is a seizure symptomatology where we can see whether there are subjective or objective, and objective consists of non-motor and motor features. Yeah. Coming to the etiology of epilepsy, which involves structural, metabolic, genetic, infectious, immune, and unknown. And there are some genetic generalized epilepsy, which involves idiopathic generalized epilepsies, childhood absence epilepsy, juvenile absence epilepsy, juvenile myoclonic epilepsy, sporadic generalized tonic-clonic seizures. Coming to the first topic, that is structural. A high resolution epilepsy protocol brain MRI to assess the possibility of structural etiology is needed. The presence of a resectable epileptogenic lesion should trigger a surgical evaluation in patients with medication-resistant epilepsy. In patients with intractable focal epilepsy and a normal MRI, a fluodeoxygen positron emission tomography, that is FDG PET scan, is useful in looking for a hypometabolic region. Now coming to metabolic part. Epilepsy associated with inborn errors of metabolism are associated with epileptic encephalopathy, with seizures arising at any early age. They are refractory to anti-epileptic drugs. There will be severe cognitive impairment or sensory or a motor impairment. They are categorized according to the biochemical pathway involved and the age of onset. The neurological abnormalities are movement disorders and ataxia. Systemic involvement are also there. Parental consanguinity and a positive family history of a similar illness can be seen. General examination should look for dysmorphic features and an abnormal head circumference. Skin and hair abnormalities can point towards Menkes syndrome or a biotinidase deficiency. Ophthalmological signs are also very important here, as pigmentary retinopathy can be seen in neuronal ceroid lipofuscinosis, mitochondrial disorders. Macular cherry red spot can be seen in gangliosidosis, Niemann-Pick disease. Lens dislocation can be seen in sulfite oxidase deficiency. Cataracts can be seen in serine biosynthesis defects.
Rashik, just one comment here.
Yes, sir.
In Indian patients, it is never a cherry red spot. It is a slightly brownish plum color spot. Okay.
Okay, sir. Agreed, sir. Okay, sir. Coming to approach to metabolic epilepsy, where the first part which we need to do is an detailed history and examination, and then going to tier 1, which involves initial workup of basic investigations like plasma lactate and ammonia levels, blood and urine amino acids levels, urine organic acid levels, then going ahead with imaging studies and other studies which are EEG and ophthalmological assessment. Also, we can go ahead with sequential therapeutic trial of pyridoxine, folinic acid, and pyridoxal phosphate. The next set of investigations are mainly for metabolic epilepsy, which involves the tier 2 and tier 3 set of investigations. The metabolic epilepsies presenting in adolescence or adulthood involves progressive myoclonic epilepsies, epilepsies with intellectual disabilities, and epilepsies without intellectual impairment. These are the list of inborn error metabolism and their corresponding treatment, starting with pyridoxine dependency, where pyridoxine, folinic acid, and lysine restriction, arginine supplementation can be a a useful treatment. Biotinidase deficiency and holocarboxylase synthetase deficiency can be given with biotin treatment. Gluten deficiency can be ketogenic diet can be helpful in gluten deficiency. Creatinine monohydrate, arginine restriction, and ornithine supplementation can be useful in cerebral creatine deficiency, and serine can be useful in serine biosynthesis defects. Folinic acid and dihydrofolate reductase deficiency, and folinic acid can be useful in folate receptor defect as well. Thiamine can be as useful in thiamine transporter deficiency due to mutations in SLC19A3. Vitamin B6, folinic acid, and pyroxidyl phosphate can be initiated in all infants with early onset treatment resistance. Thiamine supplementation of 200 to 300 mg per day can be used in unexplained status epilepticus, also can be useful in cortical and medial thalami hyperintensities in T2 weighted sequences, as this finding could be suggestive of thiamine transporter deficiency due to SLC19A3 mutations. Thiamine can also be used in seizures related to pyruvate dehydrogenase complex deficiencies and thiamine responsive variants. Ketogenic diet. Ketogenic diet can be useful in super refractory status epilepticus, refractory epilepsy. It can also be useful in pyruvate dehydrogenase deficiency, complex 1 mitochondriopathies, and GLUT1 deficiency. Coming to infectious part. The infections can lead to acute symptomatic seizures, late seizures from initial infection onset. So infectious etiology include neurocysticercosis, viral encephalitis, bacterial meningitis, fungal infections, tuberculosis, toxoplasmosis, malaria, and HIV. So describing each one of them, neurocysticercosis, it's more prevalent in developing countries and leading cause of epilepsy in those countries, and it can occur in any stage of the cyst formation. Bacterial meningitis is seizures are usually seen in acute phase and are an ominous sign and associated with increased mortality. Late epilepsy is seen in approximately 5 to 10% of survivors after bacterial meningitis. Viral encephalitis epilepsy is most commonly seen with herpes simplex type 1, which develops in 50% of patients. Acute seizures are a presenting symptom of herpes simplex type 1. Cytomegalovirus, it is the most common fetal viral infection and can cause malformations of cortical development and calcification. Seizures typically present in the first month of life. Measles patient can present with subacute sclerosing panencephalitis, which is a chronic progressive disorder, and it is seen when infection occurs before the age of 2 years. So acute symptomatic seizures can be seen in influenza B.
Just 1 minute, please.
Yes, sir.
Measles virus can produce various type of neurological disorders depending on a time frame. Acute measles encephalitis also produces seizures.
Okay, sir.
Okay.
Yes, sir. Okay, sir.
Then we have seen measles associated renal failure, papilledema, and convulsions. That sort of syndrome came and went. It just didn't take.
Okay,
Then
sir.
there is a subacute measles encephalitis, inclusion body encephalitis, which can produce status epilepticus. And the last one is only subacute sclerosing panencephalitis. So measles is a peculiar virus, and
Yes, sir.
depending on its time frame, acute, subacute, and chronic, all forms of measles infection can produce seizures. Secondly, in your bacterial one, I think you should have defined between acute pyogenic bacterial and tubercular bacterial.
So we are coming to tubercular.
That is a more common thing in India as a cause of seizures. You know,
Right,
the
sir.
first two,
Yes, sir.
neurocysticercosis and bacteria. That
Yes,
is
sir.
more important for us.
Yes, sir.
The third comment is that in the viral, herpes simplex encephalitis is the most common form of sporadic encephalitis.
Right,
Okay?
sir. Yes,
And
sir.
since we have a therapy, it should not be missed.
Yes, sir. So, sir, yeah. Coming to congenital Zika virus, where 50% cases are associated with epilepsy, and cerebral toxoplasmosis, where seizures are associated with reactivation of latent infection. Now, as tuberculosis is a common infection in India, I have prepared 2 slides regarding epilepsy and tuberculosis. Seizures in tubercular meningitis can be either acute symptomatic, which has an evidence of 16.3 and 31.5%, and it can also present with unprovoked seizures. The convulsions in patients with tuberculosis can be seen due to 6 points. The first 3 points, that is increased intracranial pressure, cerebral edema, and meningeal irritation, can lead to early onset seizures, where generalized tonic-clonic seizures are more common. Whereas the other 3 points are tuberculoma, hydrocephalus, and cerebral ischemia, where patient presents with late onset seizures, where focal seizures are more common than generalized tonic-clonic seizures. Structural damage of brain tissue resulting in epileptogenesis involves infarction, space-occupying lesions, and gliosis. And factors associated with increased risk of epilepsy in TB is age, recurrent seizures, and status epilepticus, tuberculoma, infarction, hippocampal sclerosis, persistent epileptic activity on EEG. And how to approach towards this is adequate treatment of tuberculosis infection and early anti-epileptic drug for seizures can reduce the risk of epilepsy and improve the outcome in tuberculosis. Coming to inflammatory point, the majority of antibodies are directed against neuronal cell surface antigens, which involve synaptic neurotransmitter receptors and ion channels or related proteins. Patients with autoimmune epilepsy often present with a high frequency of seizures and or treatment refractory status epilepticus. The other features of autoimmune epilepsy related to autoimmunes are progressive mental status change, neuropsychiatric symptoms, autonomic dysfunction, facial or facial-brachial dyskinesias. Seizures are usually resistant to anti-epileptic drugs early in the course. Status epilepticus can be seen at presentation. LGI encephalitis usually present with facial-brachial dystonic seizures, thermal seizures, sensory or pilomotor type. These can be seen in other limbic encephalitis also. Paroxysmal dizziness in LGI antibodies encephalitis may present vertiginous seizures. And status epilepticus at presentation is particularly common in GABA-BR and GABA-AR antibody encephalitis. This is a table showing acute symptomatic seizures secondary to autoimmune encephalitis, where there are various antibodies associated with acute symptomatic seizures. And antibody-mediated ictogenesis is the considered pathophysiology. The treatment involves immunotherapy and anti-epileptic medications. Outcome, seizures usually terminate with remission of encephalitis. There is a potential for anti-seizure medication discontinuation and potential of enduring cognitive defects. Coming to genetic, 30% are acquired and 70% are genetic. Most genetically determined epilepsies have a polygenic basis with several susceptibility genes contributing to the disease. Comparative genomic hybridization microarray is the first step which we need to be done when we are suspecting genetic epilepsy, and associated features needs to be looked after, that is developmental delay, intellectual impairment, and dysmorphic features. Gene panels are either targeted for a specific phenotype, example, a progressive myoclonic epilepsy, or offered as a compressive epilepsy gene panel. Coming to Dravet syndrome, which is an epileptic encephalopathy associated with SCN1A gene, which is seen in 80% of patients. They present with early prolonged febrile seizures provoked by modest hyperthermia. Also, generalized tonic-clonic, tonic, and hemiconvulsive seizures are most common. Myoclonic seizures are rare. There is associated cognitive dysfunction, ataxia, psychomotor regression, and demonstrate attention deficit hyperactivity disorder-like behavior. 10% of families with generalized epilepsies with febrile plus are positive for SCN1A, and family members are at risk of presenting with more severe epilepsies such as myoclonic ecstatic seizures or Dravet syndrome. A variety of other genes are associated with Dravet syndrome. And now we come to autosomal dominant focal epilepsies, which involves autosomal dominant temporal lobe epilepsy, autosomal dominant nocturnal frontal lobe epilepsy, and familial focal epilepsy with variable foci. So I'll go through them briefly. Autosomal dominant temporal lobe epilepsy, it is associated with mutations in the LGI 30% and REL gene. It has a 55 to 78% penetrance. Presents with auditory auras or receptive aphasias, and patients usually have normal intellect and they have a good anti-epileptic drug response. Autosomal dominant nocturnal frontal lobe epilepsy. They have a penetrance of 70% and usually present with clusters of nocturnal seizures, that is tonic, dystonic, or hypermotor. They usually respond well to carbamazepine and zonisamide. And also KCNT1 mutation has a more severe form that is associated with intellectual disability. Familial focal epilepsy has variable foci with mutations. It accounts for at least 10% of familial frontal lobe epilepsies. And the onset varies from 1 month to 51 years of age and average of 12 years. A short note on glucose transporter type 1 GLUT1 deficiency syndrome, which is associated with SLC2A1 gene mutation, where patient presents with seizure clusters and status epilepticus during fasting, that is before breakfast, and their associated features are severe psychomotor retardation, dystonia, ataxia, and acquired microcephaly. It can present as an early onset absence epilepsy or myoclonic astatic epilepsy. Diagnostic clue is a low fasting CSF glucose level, an excellent response to ketogenic diet. Periventricular nodular heterotopia is an X-linked dominant disorder, affects female patients, and seizures are present in 90% of patients. Perinatally lethal in affected males. As a consequence, half of male offspring perish and half of female offsprings are affected. These are some images showing periventricular nodular heterotopia. The mutations in the mTOR pathway can lead to a spectrum of malformations, which includes focal cortical dysplasia, hemimegalencephaly, and megalencephaly. These are some images showing cortical dysplasia. So in the absence of a family history or evidence of specific genetic syndrome, the epilepsy risk is general population is 1%. Child of a mother with epilepsy is 2.8 to 8.7%. Child of a father with epilepsy is 1.0 to 3.6%. Genetic counseling for a specific epilepsy syndrome can be straightforward in patients with a 100% penetrance syndrome. To summarize the topic, a systemic approach to a new onset seizure will help us to categorize patients with increased risk of epilepsy. If a patient with a new onset seizure presents, then the first thing which we need to do is identify the seizure semiology, and then to identify the etiology of seizure, which involves the main 6 points. MRI showing structural abnormalities and EEG showing interrupted epileptiform activities leads to 60% chance of recurrence of seizure. Genetic epilepsy is associated with features like development delay, intellectual impairment, and dysmorphic features. Seizures due to inborn error metabolic disorders should be identified as they are treatable disorders. Thank you. And I'll hand over my presentation to Dr. Azad Irani, as Azad sir has also prepared some slides.
Reshik, just put the last slide.
Yes, sir.
The first point showing MRI showing structural abnormalities and EEG showing interictal epileptic activities. Okay.
Yes, sir. Yes,
Is
sir.
it true for neurocysticercosis or tuberculosis?
Sir,
I
I
think
think, sir,
that's
we
very
might.
relevant to our situation, no?
Right, sir. Right, sir. Yeah.
Okay.
Yes,
I
sir.
think
Yes,
this
sir.
is more in case of cortical dysplasia, etc.
Okay, sir.
In infections, this statement may or may not hold true. I don't know. Okay.
Yes, sir.
Fine. Azad, over
Yeah,
to you.
yes, we have 3-4 minutes. So,
Yes, I'll stop screen
yeah.
sharing.
Yeah. So, he just made a small presentation at the end of the first 2 chapters. At the end of the first 2 chapters, this was one slide which Dr. Harsh showed, which showed the latest seizure classification. And then The column besides it shows the etiology, which Reshik spoke about. So at the end of this all, we still have a couple of practical doubts which the student always comes up and asks. And this is the doubt. Often asked question after a first episode seizure is, do we still start the anti-seizure medicine or no? And that's, despite doing all these 2 chapters and reading them, that doubt still comes up. So I thought of making just 6 or 7 slides to answer that question. So there are 2 questions which need to be answered. Number 1, do we start the anti-epileptic? And number 2, if we start, do we continue it for a long term? These are the 2 questions to be answered. And rest, we will also just look at this definition, what it really means. Like Dr. Katrak just pointed out right now, very correctly, that does this definition really hold true every time? The answer is no. And that's what we'll just quickly go through. So let's go through this definition first, which will make it easy to answer question 1 and 2. Now this definition, how do we approach this definition? Question number 1, let's first see if it is a seizure. That's the first part of this definition. Is it a seizure? So obviously that is by our clinical acumen. Next, number 2, in this definition, the next part is it really unprovoked? So if it is provoked due to say a toxicant or withdrawal of a toxin, etc., then it is not, then it is classified as provoked and we can let it be. Of course, after doing a MRI and an EEG to rule out a second cause, we may not just go ahead with the history. Step number 3 is, what is this estimated 60% or greater risk? Now, any patient who has a spike or sharp wave on the EEG, which is an epileptogenic abnormality, not a seizurogenic, epileptogenic abnormality. And number 2, like Dr. Katrak asked, it should be a chronic structural lesion on the brain imaging. What does this mean? It means that the MRI abnormality needs to be remote. It needs to be old, not acute. It needs to be chronic. So a seizure in setting of an acute stroke, or let's say an acute subarachnoid hemorrhage or a venous sinus thrombosis or a neurocysticercosis, acute lesion, we definitely need to start them on an anti-epileptic drug because there is an abnormality and the patient has come with a seizure. However, this will not be a long-term seizure medication, and it will be only for the short term, as we know for natural history. For example, maybe for a subarachnoid, we may continue it only for 1 week to maximum 6 weeks. For a venous sinus thrombosis, it may go on for 3 months to 6 months. For cerebral malaria, it may just be a few weeks. So based on the known natural history, it will be only for a short term, but yes, we will start it. However, let's take the same condition of a stroke causing seizure. If the stroke occurred more than 3 months, 4 months, 6 months ago, and now the patient presents with a seizure and the MRI just shows the old scar, this probably is scar epilepsy and becomes epilepsy. So this is the meaning of chronic structural lesion, which is needed for the MRI abnormality. Acute brain imaging abnormality does not classify as 60%. And last but not the least, was this really single? Like mentioned in one of the slides by Reshik, 20% of patients who present with a first episode of seizure have actually a missed history. That means 20% of patients actually have a history. They probably had a seizure in the past. This seizure may not have been picked up, or it might have been a childhood event like a bitten tongue bite in sleep, or repeated anxiety in children, which often are epileptic auras, or just blank staring looks, which all must have been missed. So again, so all words of this definition are actually important, and to call somebody epilepsy, each and every word needs to be ticked out right. This is just an extra slide where it shows that it's not just the MRI brain and EEG, but if the child also has an abnormal developmental history, if the timing of the seizure, that means the seizure was a nocturnal seizure, even if it is single, and if there is family history, all of these point more towards epilepsy, and if all 5 are present, it is 90%. So yeah, this was already described by Harsh that seizures within 24 hours are counted just as 1. Okay, so don't count it as 2, because then that will change our entire decision to start or not start the medication. So yes, just to complete that, that's how we can basically group patients into 3 categories. Number 1, a provoked single seizure. No, we don't stand at anti-epileptic drugs, and obviously they will not need it long term. Next group is the acute symptomatic seizure like neurocysticercosis, venous sinus thrombosis, acute stroke, acute infections. Yes, we start an anti-epileptic, but no, we don't give it long term. And last category, yes, yes to both. That means if the patient fits into an epilepsy syndrome, yes, we start the anti-epileptic even after a single seizure if there is MRI, EEG correlates, and it will be continued long term. Thank you.
Excellent, Azad. Thank you for that. Any comments from the faculty members before we go to the third one?
They've not
I
left.
just want to say that these guidelines, I mean, these are guidelines as always, and they're not absolute truths. For example, what is a provoked seizure? If 100 individuals were provoked with some challenge, only a few will develop a seizure. So it's possible that they have a low tendency to epileptogenicity, which is brought out only in certain circumstances. Are they to be treated exactly like those in whom seizures don't get provoked? We don't know. So I think these need to be used as a guideline, and individual case has to be treated as an individual on its own individual merits. Yeah.
May I comment on that?
Sir, please.
During World War II, when British soldiers were interrogated by the Germans and were sleep deprived for several days, a large percentage of those British prisoners of war got seizures. So a normal individual, as you mentioned, may have a very high threshold to sleep deprived seizures. Whereas a potentially epileptogenic person, potentially, may have a low threshold to sleep deprivation.
Correct.
So that is well established.
Yeah.
Therefore, when you have a first provoked seizure because of sleep deprivation, one has to wait for another seizure to occur before one starts treating that patient.
Correct.
As an epileptic.
With the knowledge that this person may get another. I mean, just now we are excluding them.
Or a sleep deprived EEG shows you a epileptogenic focus. I think
Correct.
that is the value of the sleep deprived EEG, which we try and do. Sleep as a provocating factor.
Yeah.
Ashok wants to say something.
Ashok, you're muted.
It is a very good idea, but then sleep deprived is not there, then you do it for 2 hours. If that is not there, you do it for 3 days sleep deprived. If that does work, you stop treatment for 3 days and then again do a 3-day sleep deprived. So there are multiple tiers that we can go to provoke a seizure to find out the focus, whether it's going to help, whether it's going to make any role to go ahead even more for surgical intervention.
I think, Ashok, what you are saying is in a sort of epilepsy clinic. I'm talking about the general.
Correct.
General neurologist.
General neurologist and sleep deprived is far better than a routine EEG.
Which is a epilepsy clinic and epilepsy specialized units. They will have different guidelines and different criteria.
Correct. So this point is well taken, what you have said.
Fine. Okay. So I think we have to dig into the history to find out whether there is any provocation.
Absolutely.
For example, recreational drugs.
Yes.
I'll give you a specific example. I had a lady who was a Marwadi Jain, and she came in with her dupatta right across the face. I could not even see her face. And she had a generalized tonic-clonic convulsion. She was admitted. And when I looked at her forearms here, I found multiple puncture marks. And we found out that she and her husband both were addicted to drugs. And I just found one. But when I asked Dr. Dungaji about it in those days, he says these drug addicts will find ways and means of injecting their drugs where you cannot see them, the injection sites. including intraurethral injection in males or females, intravaginal injections, and injections into the nipples. He said he's seen it all. So what I'm trying to impress upon is that sometimes appearances are very deceptive and the provoked convulsion may be totally missed if you do a superficial examination.
So the point I was making was that if there is a provoked convulsion, that person still has something different from normal people, maybe a less threshold of recurrence, but it is there. So I think you may choose not to treat at that time, but you have to keep him on the radar, and he has to be on the radar all his life.
Provoke convulsion after the age of 7 in adults. In an adult,
At any time, I think a seizure is a seizure.
Except simple febrile seizure below the age of 5, which is generalized with fever.
Well, a lot of them will turn into something, MTS and generalized seizures. And
okay.
I think the very occurrence of a seizure, under whatever circumstances, there is always a possibility that it may come back. But our statistics tells us how much is it, and is it necessary to start them on medication? I think this is the whole effort about. Yeah. Okay,
Right.
so we go on to the third one.
Yeah, the
third presentation
is Arjun Shah.
Optimizing. Sorry, Ashok.
Yeah, he's from JJ Hospital, and he's doing a double header. So this weekend also I'm having a double header. We are optimizing medical treatment for epilepsy, in which case we are talking mainly on tricks on how to see to it, how to ensure the patient takes the medicines correctly. And the tough one is he's talking about points made on how do we go ahead for medically refractory epilepsy. And that I think Dr. Karthik will have many, many points to make in that. So
now,
he's working very hard, working till 11 at night and 12 at night. So Arjun, it's all yours. The stage is yours.
Just one sec, Ashok.
Yeah.
I think we have given him a little extra time, no? Because he's covering.
Azad has given him 30 minutes. I've told him be a curtail to 30 minutes. Not to worry, sir. If it goes ahead,
yeah, fine.
We'll beg for time.
Yeah.
Professor Azad is very strict, sir.
No. You can borrow a little bit of my time.
Okay, Arjun, you're a lucky guy. Okay, go on.
Are my slides visible and is my voice audible?
Yes, all well.
Both.
Yes, Arjun.
Good morning, everyone. The first of my topics will be optimizing management in medically responsive epilepsy. And I've prepared these under the auspices of Dr. Ashok Sirsat, sir. So once the hard work of seizure remission has succeeded, we often pay less attention to maintaining this seizure-free status. What we should realize is this is by no means the end, rather it is the end of the beginning, and now we must start working towards the beginning of the end, that is to achieve seizure freedom. Some definitions, unfortunately, the entire realm of epilepsy is plagued by these complicated definitions that we need to understand. 2 out of every 3 patients can remain seizure-free if we put them on appropriate medical therapy. And there are loads of definitions of breakthrough seizures, but this is the one which is given by the ILAE, and this is the one we shall be using for this discussion. It's defined as one that occurs despite the use of an adequate seizure medication that has otherwise successfully prevented seizures in the past. And when we say it has successfully prevented seizures in the past, what do we mean? We mean that this epilepsy was medically responsive epilepsy. That is seizure freedom for 12 months or 3 times the longest seizure-free duration, whichever is longer, before the medicine was started. So just to understand how important and what implications this has, patients who have breakthrough seizures incur 2.3 times more healthcare costs, which translates to a lot in today's world. It causes interruption of schedules, it causes injuries, head injuries, it causes loss of work. A lot of people still don't realize that epilepsy is a treatable disease, and a lot of employers do not understand where their employees are coming from. It has a major role on driving privileges, especially in countries and places where we don't have the privilege of chauffeurs and one has to do all the driving by themselves. It can cause sudden death in epilepsy, and this is something we often forget to appreciate. And
Arjun, more
hospital
likely,
charges are greatly increased because of increased admissions and loss of work.
Arjun,
Yes, sir.
it is not people who don't have chauffeurs. It is very important in cities where public transportation is a minimum.
Absolutely, sir.
It's
Yes,
not
sir.
chauffeurs. Public transport is more important. For example, in many cities of America, there is hardly any public transport, and therefore they are dependent on their cars and driving.
Zero public transport,
Yeah.
zero.
For example, I'll give you a specific example. Orlando has no public transport.
Right. Um, so self-management is basically those activities or those steps that an individual or the family members of a patient can perform that will help control the frequency of seizures and in general promote the well-being of this said person with seizures. So it's very important that to ensure victory, the doctor and the patient should be reading from the same playbook and should have fixed set objectives from treatment. So what are some of the risk factors for a breakthrough seizures? For a breakthrough seizure, so one can sort of figure out a patient is more likely to have a breakthrough seizure or not if there are any prior deficits, including learning disabilities, the total number of tonic-clonic seizures that a patient has had before he has achieved seizure freedom, and the time taken to achieve said seizure freedom. So this would give us an idea of which patients to be more vigilant about. And so adherence is a very, very important thing, and a gentle skepticism goes a very long way. At every meeting, we should inquire about adherence and not take it for granted that patients are going to be adherent to the medication. In fact, a study by the WHO showed that across diseases, almost 50% of patients were not adherent to their medicines. And there are a lot of ways in which we can maintain this adherence, but a good history is and a good patient education is the most effective. So, as expected, adherence rates dropped drastically from an OD dose to a 4 times a day dose from 87% to 39%. Again, not surprisingly, if someone is taking a single drug, they are more likely to be adherent rather than someone who's taking multiple drugs, and it goes up to almost 71% of non-adherence. The age is also very important. A lot of patients have epilepsy from childhood, and once they start getting into adolescence or early adulthood, they are sort of kept independent, or they think that they are independent, but they're not really. They still require little supervision. So this is when they're most vulnerable to non-adherence. A lot of local medicines and herbal medicines do cause seizures, do cause breakthrough seizures. For example, eucalyptus that is used very often in the Indian household is known to lower the seizure threshold. Ginkgo biloba, which is again being prescribed quite often, not only lowers the seizure threshold, but also lowers the anti-seizure medication levels. And a lot of Ayurveda medicine like Shankhapushpi, which is used as a nootropic, is known to lower the anti-seizure medication levels. So we need to figure out what other therapy the patient is taking. Drug interactions are also a very important cause of breakthrough seizures, other medications, and sometimes dietary changes. There are a lot of food fads today. In our country, what's very important is anti-tuberculosis medications. Almost all of them have some sort of interactions with the anti-epileptics. Another important thing is lamotrigine, which is usually used in female patients, and OC pills. And OC pills are known to decrease the lamotrigine levels by almost 50%. Phenytoin and tobacco, so someone who's taken up smoking and has been on phenytoin, this also might be a cause for breakthrough seizures. So this is just a general list of all the drugs and which cause interactions. And it's important to know, like in myasthenia, we give the patients a list of drugs to avoid or be careful about. We might want to do the same for epilepsy as well. There are other causes like low socioeconomic status and other comorbidities, especially psychiatric comorbidities, tend to increase the chances of having a breakthrough seizure. So what are the ways in which we can improve adherence? So the most important thing is counseling and patient education. Patients need to be educated about what exactly the disease is, what exactly the medicine is, and how it's going to help them in the long run, and what can happen if they don't follow the advice to the team. Reinforcement is very important, especially to children. Some positive reinforcement can go a long way. Sometimes children won't understand concepts like mortality. It's very abstract. So we need to make them understand in their own language. Like they won't get to play with their friends if they keep getting seizures, something like that. With all the technology in the smartphones that everyone has, there are loads of reminders, apps. You can set alarms that can remind the patients to take the medicine. Supervision is very important, especially for very young patients, very old patients, and those with psychiatric comorbidities. And we must talk about adherence every chance we get. So the wily physician can aid by giving specific instructions. For example, we can tell them to have their anti-epileptic medications with meals, breakfast, lunch, dinner. So this is a lot easier than telling them to have it 3 times a day. Education about epilepsy helps, and this is statistically proven by Dash et al. That showed statistically significant levels of compliance after patient education, and Parker et al. Showed the same with behavioral therapy. Monitoring drugs serum levels have a very limited use, and generally they're not required. A good clinical assessment and a good history and a good conversation with the patient can usually be enough. Again, sometimes when we are switching drugs that work, this can cause breakthrough seizures. And the reason we switch these drugs is if they have side effects, or if the patient has gotten pregnant, or some new comorbidities have come up, like a patient has become a transplant recipient. So this is the time when we need to have more vigilance, because this is when a patient is susceptible to breakthrough seizures. Sometimes we need to change the medicine because of other causes, such as financial limitations. And a situation we see more often is the insurance companies not covering the medicines. And another important thing is current data suggests that if we switch between different generics of the same medicine, it is not associated with increased seizures. So pushing the patient to buy the same brand or not avail a cheaper generic drug sometimes might not be in their best interest. So we need to know all the different seizure precipitants, and this is something we need to bring out from the history. So by far, stress is the most common of the known precipitants. And it's interesting that after the 9/11 terrorist attacks, there was a documented increase in breakthrough seizures. Sleep deprivation is another very important factor. So we need to teach these patients to have a regular sleep schedule and maintain sleep hygiene. As expected, fever, fatigue, even weather changes can cause breakthrough seizures. Certain cartoons can cause seizures in children. For instance, there was an episode of a famous cartoon, Pokemon, in 1997, after which 687 children actually got seizures while watching this cartoon. And here is a still from that. So bright lights and cartoons also should be avoided in young children with epilepsy. Menses, caffeine, even fasting for prolonged periods can cause epilepsy. An interesting thing is alcohol is very rarely associated with breakthrough seizures. Indeed, withdrawal from alcohol does cause seizures, but alcohol in itself hasn't been known to cause breakthrough seizures. So managing seizures due to precipitants is simple. Firstly, we must treat the acute seizures adequately. A detailed history, including all allopathic and non-allopathic drugs, sleep schedule, work schedule, personal life details of the patients must be taken. If we are sure that the patient is adherent, it warrants modification of therapy, but very often we'll find that the patients are not adherent. And we need to identify precipitants, if any, and naturally work towards avoiding them. And we need to work towards seizure freedom and inculcate this goal in the patient's mind as well. A few other things like yoga, a randomized controlled trial showed improved quality of life and reduced breakthrough seizures in patients who are on yoga. So whatever works for someone should be encouraged. So in summary, the importance of a clinical history, especially medication history, is very important in patients with breakthrough seizures. It is essential that we educate patients about their disease and their the medicines. And we must try to inculcate an epilepsy lifestyle, that is attempt to meditate, or perform yoga, or maybe to take their drugs regularly to maintain a good sleep cycle, and that can help in reducing breakthrough seizures. Thank you.
Can I make a comment, please?
Yes, sir.
Yeah. You mentioned about if drugs are expensive and not covered by insurance. Okay. That is usually not the problem in India. I'll tell you my experiences at JJ Hospital. In those days, carbamazepine was more expensive than phenytoin. Now it's the reverse ratio. But we used to give phenytoin from JJ Hospital dispensary, and a patient continued to have convulsions. So I asked him to switch over to carbamazepine, which was not available and I prescribed Mezatol and asked him to take it from the market. I asked him to take it 3 times a day. And he came back after a month to tell me that the seizures were not controlled. And I was racking my head. So I asked him, are you taking the drug properly? So then he felt very ashamed and said, Dr. Saab, your drug is so expensive. So should I take the drug and allow my children to starve? That is the state of India, not insurance. Sometimes the drugs are unaffordable to the patients. And they take less drugs because they want to feed their family. Please remember that.
So now the problem is different. Now it's a problem with
No,
Brevilicetine.
I'm just
We
trying
face
to
that.
point. No, I will.
Yeah, you're absolutely right. Absolutely
Dr.
correct.
Dr. Mani, when he started doing his village surveys, rural areas, you know, and I think Dr. Praveena Shah will also bear me out. Okay, when you go into the rural areas, it is better to give drugs like phenobarbital or phenytoin, which are relatively cheap, and get a somewhat control of epilepsy, rather than prescribe very expensive drugs and get no control of epilepsy because the patients will.
Or you supply them fully.
Yeah.
Or you supply them fully.
Yeah. So that is the problem with India. And these boys have to understand that. Reading a continuum is a very American perspective. Please change your perspective from what you read and apply it to what is relevant in India. Otherwise, I think your coverage was very good.
Very good. Very good. Yeah, the next talk is even tougher. That is what we were discussing about the first time. Is talking about refractory epilepsy and how do you go about it. Yeah, please, Arjun.
So the second topic for today is
the first talk was very colorful slides.
Yeah.
And when you get down to refractory, it's just a plain green.
He's very, very talented.
by
Yeah?
design.
He's very talented. He's very talented.
By design.
I know Arjun Shah. I've been taking rounds with them. So I know all the guys.
Yes, sir. So the second topic is identification and treatment of drug-resistant epilepsy. So the contents of this would be, firstly, how do we identify a patient as being drug-resistant? What evidence we have for surgery? The caveats of epilepsy surgery, a brief note on pre-surgical assessment, the armamentarium that we have surgically, and just a quick illustration to see how we can apply this in our practical lives. So drug-resistant epilepsy is defined as the failure of an adequate trial of 2 tolerated and appropriate anti-epileptic drugs. They can either be used separately or together to achieve sustained seizure freedom, which, as we've discussed, is 3 times the prior inter-seizure interval, or 1 year, whichever is longer. So as we've discussed, 2 out of 3 patients.
Arjun, I've got one difficulty with this diagnosis, with the previous slide.
Yes,
why would anyone combine 2 drugs at the word go?
No. One minute. Hey, no. See. I would like to answer it, Arjun. Arjun, I would like to answer it. What he has written is of 2 parts. There's no implication that he's combining 2 drugs at one shot. You normally give one drug. If that doesn't work, you add the second drug. And this is the model, and this is the whole definition, and the model has come from Kwan and Brody in the New England Journal of Medicine. So it's a failure of adequate trial of 2 tolerated and appropriate So there the point they made is they reduce seizures in 20% of the population of 1,000 plus patients merely by stopping carbamazepine, phenobarbital, and what have you, and they just added valproate. That means many patients with juvenile myoclonic epilepsy were being treated with non-valproate group of drugs, and that is what has happened. So that is why the model they've drawn is one drug doesn't work, add a second. But the question is, the caveat is, it has to be tolerated and appropriate. So you must have the diagnosis correct before starting treatment. And many people who come to an epilepsy clinic has come with the wrong diagnosis. So that's the point. What is new in this, and I would like to make Arjun, if you don't mind, one more sentence I would like to say. What is new in this continuing chapter is the second part of the definition. That is, the effectivity of drug has now got a certain time frame, and there's a reason for that. This time frame is 3 times the prior interseizure interval, or 1 year, whichever is longer. Now, this is because you can see that graph, the way the number of medicines have gone up in the last 25, 30, in the last 30, 35 years. But the overall incidence of epilepsy in the population have not come down. The number of seizures per human being in the population have not come down. So all that they're saying that the side effect profile is better and X drug is non-inferior to the Y drug. That's all they're trying to say. So the question is now, time has come to put the doc and the pharmacologist on the mat and make it very clear the effectivity has to be significant. It has to at least 1 year, it has to be effective, or whatever was the interseizure interval, it has to be 3 times more effective than that interseizure interval for you to say that this drug is good. Satish, you got me?
Yeah. No, let me sort of ask this. You start a
Yeah.
patient on one medicine, which you think is appropriate.
Yes.
It doesn't work.
Yeah.
You shift to another drug or you add a second drug.
Now that is, the Peduca has answered this question very well. He says, if you add another drug and it works, technically speaking, you should reduce the first drug. And he's very adamant about that. But he says nobody in practice does that. And he's a pharmacologist, he's a neuropharmacologist. Nobody in practice does that for the simple reason, if the patient develops a seizure, he's not going to come back to you. He's going to get off the medicine for good. The fear is reducing the second drug, yes, but he's absolutely adamant that you must get rid of the first medicine.
Let's ask Dr. Khan, who has a long practice, and Dr. Katrak.
Yeah.
From one monotherapy, do you shift the patient to second monotherapy, or you add a second drug?
I give polytherapy.
I mean, a newly diagnosed patient, first drug has failed. Would you move him completely to a second drug, or would you add a second drug?
I usually add a second drug, and I must confess that there is a dilemma, and very often the second drug is associated with, because as you say, I'm rather afraid that if you reduce get rid of the first drug, you may get further seizures. That does happen, and it's absolutely true. It's a practical thing. Desirably, it might be better to get rid of the first one. But in practice, as you have correctly pointed out, it very often doesn't happen.
Yeah.
May I make a comment?
Sir, please.
Yes, sir.
Yeah. Unfortunately, there are certain disadvantages of being a senior person. You get patients who are refractory resistant epilepsy, and in whom the first generation drugs have been tried and some of the second generation drugs have also been tried.
Correct.
Therefore, perhaps my most common thing about refractory epilepsy in my experience has been that this sentence, anti-epileptic drugs in appropriate doses, that part is a little missing here. adequate trial of two tolerated and appropriate anti-epileptic drugs.
Arjun, type it out. He's right. Dr. Katrak is correct.
But in appropriate doses, if you give subminimal doses,
absolutely correct. Point well taken.
The
3 cheers, 3 cheers.
Epilepsy the epilepsy is going to be refractory.
Yep. Point taken.
And secondly, in my experience, I think drug interactions between anti-epileptic drugs is also a very important issue.
Of course, that point Arjun has brought up beautifully.
Yeah.
Even anti-epileptic drugs and even non-treatment for epilepsy can come and interfere with the treatment of epilepsy.
And I'm going to reiterate that point in my talk.
Done. Well done.
But I entirely agree that these newer anti-epileptic drugs have not added to the efficacy of the drug.
Only non-inferiority. They are only pushing non-inferiority.
And lower side effects.
Allegedly. The new side effects you don't know as yet.
Yeah.
It took you 40 years to realize that phenobarbital causes shoulder joint arthropathy. It took you 40 years. It took you 40 years to realize that phenytoin causes progressive ataxia that does not improve. Come on now. Now wait for 40 years to see what levetiracetam and brivaracetam does.
Yeah, but what I'm saying is, now you select, I think the modern neurologist selects the anti-epileptic drug based on the side effect profile.
Correct. Which is not entirely perfect. It is good, but just
But we have to be practical.
Yeah, correct.
The main cause, in my opinion, the main cause of refractory is, I think, suboptimal doses of the drug.
Very important point. Just write it, Arjun. Beautiful. Yes. Beautiful point.
Okay.
Yeah. Carry on. Shoot.
Sorry, can I raise one more?
Please, Satish, I'm waiting for it. This is true medicine. This is true medicine.
Sir, when you say good dosages, you would be leaning towards the maximum allowed or maximum tolerated doses before saying it's a failure?
Correct.
Yes.
For example, levetiracetam, I would go up to 3 grams.
3 grams, correct. That's the correct dose.
Once it is controlled, then I try to reduce the dose.
Yeah. Since Ashok has been reading about it, as we go on increasing the doses, what percentage of patients go on improving?
They come and
I generally find that once I have started a drug in the standard initial doses, I generally get an indication whether the drug is working or not.
They come back and fight with you because they can't tolerate the dose very often. Our patients, 3,000
milligrams. The question is,
milligrams of levetiracetam, not 10% of my patients can tolerate.
No, Ashok, my question is, within the given range of the drug, minimum to maximum, what is the yield of increasing the doses from minimal advice to the maximum advice?
Okay, Satish, we are here. Dr. Katrak, when he talks about this, he has made it very clear. These are the guys who are not doing well at all when they reach him. So the normal guys will do well with 500 BD of levetiracetam or 600 of carbamazepine or 1200 of oxcarbazepine. So these are the normal guys. Dr. Katrak is talking about a patient population which is anyway not doing well. So he has no choice. He's pushed to the wall.
But that's different. We are just now defining drug-resistant epilepsy.
What you are talking about newly diagnosed epilepsy.
Correct. We are defining now drug-resistant epilepsy.
Those guys are...
No, we are talking about newly diagnosed epilepsy. Yes. About 60 to 65% will be well controlled on one drug.
On any of the appropriate drugs.
66%. That is the figure. Shaman Shor's figure.
In standard dosages.
In adequate doses, let me put it down, not standard doses, adequate doses, the patient, about 65% will be controlled.
Correct.
Another 15% may be controlled on two drugs.
Yes, correct.
So you come up to 80%.
Yeah.
Now, amongst the rest, 20%, a large majority may require 3 drugs.
No. Arjun is going to tell you now, large majority we're going to need surgery. Arjun, shoot.
Let me
Hold
before
on,
Arjun,
hold
before you
on.
go to this next slide.
Ashok,
Yes.
Ashok, please hold on.
Yeah.
I'm talking about my experiences.
Yes, of course.
When epilepsy surgery was not proper.
Correct. Correct.
Okay.
No, let me reword my question. You have a newly diagnosed epilepsy. You started somebody on dosages that obviously are not going to be the highest.
Yeah.
They are going to be what you would consider standard doses.
Adequate. Yeah.
And then you will go on building as he comes back to you with seizures. And it may take you 3 months, 6 months before you say that, okay, I've reached enough or the patient is not tolerating.
Yeah.
And then I'm going to add the second drug.
Correct.
So my question is, between starting doses and the maximum tolerated doses, what is the extra yield? Because if there is no extra yield, there is a reason to shift to the second drug earlier.
That point is a tough question, but then see, 500 BD of levetiracetam is given in no corner of the world except India. That is grossly an inadequate dose by any standards. But that is the most standard drug in most standard dose in our country.
But I think Ashok,
yeah,
Indians tend to develop side effects at much lower levels than
100%, 100%, 100%, 100%.
Particularly ataxia with phenytoin.
Correct. 100% true.
With carbamazepine.
100%
tolerate. So we have to formulate our standard doses.
Correct.
Okay.
Absolutely.
Now to answer Satish's question.
Yeah.
When you start giving carbamazepine, you have to titrate the doses. If you start with a very big dose initially, the patient will complain of giddiness.
Correct.
And then they will stop taking the drug.
And they won't touch it again. Yeah.
So it is important that when you have a newly diagnosed epilepsy, you start with lower doses and then titrate the dose depending on the patient's tolerance.
Correct.
Okay.
Correct, sir.
Then also you have to see the control of epilepsy.
Yes.
During the titration, the patient may get a seizure. That does not make it totally refractory epilepsy.
Correct.
Correct.
So I think the word appropriate anti-epileptic drug used as monotherapy or combination in adequate doses should be part of this definition.
Good point.
Yeah. But then the adequate will have to be defined.
Although adequate for carbamazepine is 3,000.
Okay, let's use the word therapeutic.
Adequate is different from maximally tolerated.
No, therapeutic doses.
Correct. So exactly, sir, that was my question. Within the therapeutic range, minimum to maximum, what is the extra yield?
According to me, not much.
Yeah.
Maybe even nil.
Yeah.
If you hit it, you hit it. If you don't, that means no further tricks going to help.
Okay, to answer
no magic help.
To answer Satish's question, you will have to do an intercontinental study.
Yeah.
Studying various ethnic populations.
Yeah.
Correct.
You know?
Correct, sir.
Arjun.
Probably an unexplored.
Yeah, it's a unexplored. I always make the mention, we Indians tolerate the drugs in smaller doses compared to the Western Caucasian population.
Correct.
Yes.
And I made this statement for Parkinson's disease. I made this statement for epilepsy. The medical oncologist pounced upon me and said, no, we don't agree with you. Our Indian patients take the same doses as Caucasians. Well, they get more side effects.
Yeah.
And these guys are very fond of their own protocols.
Yeah. Hey, Arjun, I warned you this is going to be a stormy topic. Yeah, shoot. Go on. Go on.
Go to your next slide, Arjun.
Arjun, shoot.
Started on a stormy. I think the next course will be more calm.
Okay. Arjun, you're there? Yeah, great.
Picture is frozen.
Arjun, you're frozen?
No. This is a new slide.
Okay,
Yes,
fine.
sir. Yes.
Yeah.
So, am I clear now?
Yeah, great,
Yes,
great.
On the appropriate AEDs will achieve control. If we add, so 11% more patients become seizure free after failure of the first drug and adding the second drug. So we have an 11% benefit by adding the second drug. After adding another drug, there's only a 3% benefit. And
Correct.
these studies were done in the 2000s. So even with all the newer expensive anti-epileptic drugs that we have, they don't really increase the percentage of
We come to 80%, which was my experience.
seizure control.
Yeah. Hello?
Yes, sir. Exactly 80%. Third of the people who are living with epilepsy, a major role on their quality of life, their social function, death in epilepsy. So this was one of the landmark studies done that compared medical versus surgical treatment for epilepsy. And this was only done for patients with temporal lobe epilepsy. And so this is where most of our initial evidence comes from. It was an RCT done on the population was adults with temporal lobe epilepsy. The intervention was epilepsy surgery, anterior temporal resection. Control was continued medical care. And what they found in this was that 58% of the patients in the surgery group were seizure free as opposed to just 8% in the medical group, with a very, very significant p-value. They also showed that it improved quality of life based on questionnaires, and they documented high. So there is this gap between evidence and practice. In fact, in 2003, the AANI prescribed guidelines for surgery for refractory epilepsy. But so far, only 1% of patients with resistant epilepsy are actually referred to epilepsy centers for consideration for epilepsy surgery. And it's an average of more than 20 years after onset of epilepsy. So we need to bridge this chasm between evidence for new therapy and actual practice. So one thing which might be a deterrent for many, even neurologists, is the safety profile of surgery. And it's ostensibly considered to be dangerous. However, the truth is that based on the studies, only 1.5% of patients had major complications, which they have said resolve within 3 months. And 5.1% have minor complications, most common of them being a simple CSF leak. Another thing is cognition and memory deficits prior to surgery are not contraindications for surgery. In fact, although after left anterior temporal lobectomy, there might be some verbal memory and naming deficits, they have shown that there might be some paradoxical gains in visuospatial memory and verbal fluency. Another thing is normal MRIs, that we think that if there's a normal MRI, that there isn't any structural lesion. However, not all normal MRIs are actually normal. Indeed, a structural abnormality on an MRI will lead to better surgical outcomes because we have a delineated structural problem. But a normal MRI might not be normal because the patient might have a disorder like focal cortical dysplasia. And it's almost 60% of these patients will have a normal MRI, and these patients will benefit from epilepsy surgery. So what's important is not just to rely on MRI, but a detailed clinical examination, a detailed history as to where the seizures are starting from, whether they have a focal onset, an EEG, an MRI, a SPECT, PET, and all the other various interventions that we have now. We need to define an epileptogenic zone, which is basically and we define this in surgical terms as the minimum amount of cortex that must be removed or inactivated if we are not doing a surgery to achieve seizure freedom. So this requires multimodal evaluation, and focal lesions and MRI don't always localize the epileptogenic focus. So just as a normal MRI doesn't mean that there is no abnormality, an abnormal MRI does not mean that that is causing the epilepsy. So some caveats of epilepsy surgery. Firstly, this entire debate about the eloquent zone, we should exert caution if we are referring these patients for surgery, but it's definitely not a contraindication. And with the newer modalities and careful mapping, we might be able to resect without causing too many permanent deficits. And if we can't do surgery, neuromodulation might be an option for these patients. If someone has multifocal lesions or generalized interictal spiking on the EEG, again, often we think that they are not candidates for surgery. However, again, a detailed clinical history, EEGs, and all other modalities that we have should be utilized, because sometimes what seems to be generalized might be starting off as a focal onset, with a focal onset, which might be amenable to resection. And if not surgery, perhaps vagal nerve stimulation can be considered. And almost 60% of these patients have a 50% plus seizure reduction. Now, although these numbers seem very large, these are usually patients that have many seizures in a day, even daily seizures. So even a 50% reduction might not really translate to improvement for them. Again, psychiatric comorbidities, often these patients are neglected, and we think that the psychiatric issues are the predominant pathology, but this is not a contraindication for surgery, and there are no significant psychiatric complications of surgery. In fact, there is a decrease in anxiety and depression when patients are actually seizure free. So we must consider the burden of antiepileptic drugs and seizures as well when we compare them to the taking a patient to surgery. Epilepsy centers, this is something we don't really have in our country, but we need to understand that we need.
Sorry, Trivandrum has done over 2,000 surgeries for epilepsy.
Yes. So there are very few in our country, is what I meant to say.
Compared to the problem in our country, oh God, the stories that I can tell you are not funny. Trivandrum is phenomenal. Now the center has moved out, not so much to Sri Chitra, but they moved out to Palakkad. And Delhi is doing a lot of work. Mumbai and Pune are doing it in their own small way. But there are at least 10 major metros where the incidence of epilepsy surgery is zero, and where there are more than 10 neurologists. 10 major metro with 10 practicing neurologists, the incidence of epilepsy surgery is zero. If you listen to Hans Homgarter, why India is doing so few cases, you will be shocked. I will talk to you in person. Yeah, you're right about that. The number of patients in Trivandrum are maximum, but we are in.
Ashok.
Yes, sir.
Indians are basically very shy of any form of surgery.
But when you see the cure.
I know.
I have people who are married.
The transition phase of refractory epilepsy with 3 drugs to surgery for epilepsy.
And they go stop 1 drug, 2 drugs, and some of them get married without any medication.
What I'm saying
succeed, it is God's own success.
No, what I'm saying is
that
by the time the patient is referred for surgery,
it's too late.
It is already too late in India.
So that's the point Gaurav is making.
Yeah.
And this all over the world, not only in India. Why in India? That's the point he's made. He's got evidence for that.
I know.
Shoot.
That is the point that all epileptic centers are making.
Yeah.
That by the time you all refer the case for surgery for epilepsy, there is a mirror focus on the opposite side.
Correct. Yeah, carry on.
These centers are required not just for surgery, but also for pre-surgical workup and to rule out pseudo seizures and to evaluate their prior medications and adherence and all of that. So there are some advanced tools that we use and for figuring out what is the epileptogenic zone. So the first is grids and strips. So again, this requires an epilepsy center. First, we need to do a craniotomy, and then these are placed subdurally. So this is how they look. We do a craniotomy and then we place these, and these are numbered. And after that, they are connected to the video EEG, and the patient is observed in the hospital. And when the patient does get the seizure, it is an attempt is made to localize it based on these numbers. So we know exactly how much cortex to remove to achieve seizure freedom. Another thing that is used nowadays is stereo EEG, which gives us a 3D analysis of, which is basically 3D analysis of many contacts placed deep into the brain with stereotactic guidance. And again, it's something like this that we figure out, we insert these sort of nails into the patient's brain. And again, the patient is observed for a while, more deeper parts of the brain. The epilepsy near the eloquent cortex, so we cannot insert these stereo EEG contacts, then we use grids and strips. And if we are suspecting that there's a bilateral or a deep focus, then we prefer stereo EEG. So just quickly going through the surgical options that we have, the gold standard for this is resection, and the resection can be callosotomy, hemispherectomy, a disc connection surgery, and the number needed to treat for this is 2. Now, what we must realize is this number is derived from the studies on temporal lobe epilepsy, so it might not be applicable to all sorts of epilepsy surgery. However, this is a very, very good number because if we compare it to other interventions that we use, for example, carotid end it's 10 in the first 3 hours and 19 till 4.5 hours. So an NNT of 2 is a very promising thing. Another thing we can do is thermal ablation. This is a very minimally invasive surgery, sound-induced thermal ablation. However, this is exorbitantly expensive. Neuromodulation like vagal nerve stimulation can also be used, especially when the focus is in the eloquent cortex and we're not very comfortable doing a resection. VNS won't give immediate outcomes, but over time, the efficacy does improve. But only 8% are actually seizure-free after 2 years. So this can be used in patients who have too many seizures and would benefit from even a slight reduction in the number of seizures, or if they cannot undergo surgery. However, it's still prohibitively expensive to do. So just to illustrate, they've given a summary in the continuum of how we can apply this for our patients. So let's suppose we have a patient who's come to us for the first time. So the first thing obviously is to diagnose epilepsy in a patient. And as alluded to earlier, this is the definition that we use to diagnose a patient as having epilepsy. So we can start drug number 1, which is adequate, appropriate in the inadequate doses. We need to monitor the response, side effect, blood levels only if required. We can either switch or add on drug number 2 if drug number 1 is not effective. Again, the same thing, monitor, response, all that jazz. Finally, if these 2 drugs in the tolerated and appropriate doses have not been able to cure the epilepsy or to treat the epilepsy, then we need to label this patient as having drug-resistant epilepsy and refer to an epilepsy center. So in the epilepsy center, what happens is first they'll try and confirm the diagnosis. They'll rule out pseudo seizures. They'll check whether the patient is adherent or not. Maybe try some other treatment options like a keto diet or behavioral therapy. And once they've confirmed that this is resistant epilepsy, they'll try to figure out whether the patient can undergo surgery. So a detailed pre-surgical evaluation is done, which includes MRI, PET scans, SPECT scans, even functional MRI, various EEGs, stress EEGs, neuropsychological analysis. The WADA test is not really used nowadays. It used to be used to figure out what the dominant hemisphere is. Then there is some intractable monitoring to confirm that this is a localized epilepsy, to confirm that this is exactly the epileptogenic focus. And as we've discussed earlier, video EEGs, grid strips or depth electrodes for deeper foci are used, stereo EEGs, and functional brain mapping. And once that is done, we can consider the patient for non-pharmacological therapies, resection being the most effective. For deeper structures, thermoablation might be used. If there are multiple foci or if the eloquent cortex is involved, neuromodulation might be preferable. And if there are more than 2 foci or generalized epilepsy and we still, the patient cannot be treated with pharmacotherapy, then we can consider vagal nerve stimulation. So in summary, 33% or 1 out of every 3 patients are on the path of being drug resistant, and surgery might be the answer for them. So it's very important that we educate ourselves and the patients regarding all these newer technologies that are coming our way, and that we know that surgery is not as dangerous as it seems. And it's very essential that a multidisciplinary approach should be inculcated earlier. So it's not too late by the time we actually decide to go in for surgery. Thank you.
I would like to add something here. Recently Medscape had a very nice CME on when to use neuromodulation in treatment of refractory epilepsy. And there was a very nice chart there. So I will just read it out to you. If the clinical factors is that the patient declines brain skull surgery, then vagal nerve stimulation is the treatment of neuromodulation of choice. If the seizure focus or foci are unclear, then you can try out vagal nerve stimulation or more recently deep brain stimulation. Invasive or difficult workup to localize foci. Again, you can use vagal nerve stimulation or deep brain stimulation. If there is a well localized focus but not resectable by surgery, then you can use what is known as regional neurostimulation. That means they have an electrode going into the focus, and minute the focus discharges, it stimulates a battery which counteracts and gives a shock and puts it into the refractory stage. Depolarized state. So that is there also, regional neurostimulation. Recording EEG is desired for future, again regional stimulation. Posterior seizure focus is unknown. And untreated severe depression, vagal nerve stimulation seems to be the neuromodulation of choice. And as I mentioned earlier, I think by the time the patients go for surgery evaluation, I think it is a little too late. Part of the fault lies with the doctors who do not evaluate the patient, and part of the is with the patient himself. You say, let's go in for surgery of epilepsy, and you see the reluctance. Okay. So I have no further comments to make.
Yeah, actually, we are also over time. So shall we? Shall we move on? We actually half an hour over time, and we've had discussion on this topic. So if someone has a comment, we'll take it, or we go to the next one.
I only want to say that Arjun worked very hard and did a phenomenal job. There were 3 nights.
Yeah, he was really very good.
WhatsApp, and I've been quite aggressive with him, and he took it very well. Thank you, Arjun. Very well done.
Yeah, and so it was a difficult topic also. Yeah.
Ashok, normally you're aggressive.
So next is Dr. Aditya.
I learned it from someone.
Yes.
Aditya Aundkar, EEG in epilepsy evaluation.
Yes, I'll just start screen sharing.
And
Am I audible,
the
sir?
mentor is Purnima. Purnima is here. Welcome, Purnima. Purnima, are you there?
Yes, sir. Yes, sir.
Yeah,
Just
welcome.
unmuted myself. Thank you, sir.
Welcome.
Thank you. Yes,
I think both of them should light up their screens.
Yes, sir. Am I audible, sir?
Yeah, Aditya, we can see. Purnima, if you can turn your video
Yes,
also on.
yes.
Thank you. Yeah, Aditya, do go ahead.
Good morning, everyone. Today I'll be talking on EEG in epilepsy evaluation, and my mentor has been Dr. Purnima Shah, ma'am. So EEG signals are generated by cortical neuronal postsynaptic potentials, and they provide real-time assessment of cerebral physiologic function. They play a crucial role in the diagnosis of epilepsy, and they also help in classifying seizure types and epilepsy syndromes. This talk shall focus on a bird's eye perspective of common interictal and ictal findings on the scalp electrodes. So interictal epileptiform discharges are defined as paroxysmal and distinct from the patient's normal background activity. They must include an abrupt change in polarity occurring over several milliseconds, and the duration of each transient should be less than 200 milliseconds. These discharges must have a physiological field, and they must be recorded for more than one electrode, where a voltage gradient is present. So as you can see here, a spike wave has a duration of less than 70 milliseconds. So it is between 20 to 70 milliseconds. And a sharp wave has a duration between 70 to 200 milliseconds, and it stands distinctly apart from the background voltage. So IEDs, they must be differentiated from benign variants or normal discharges, such as wicket spikes, small sharp spikes, muscle eyelid artifacts, vortex waves, etc. So IEDs aid in the determination of epilepsy as an etiology for suspected clinical events, but the absence does not exclude the possibility of epilepsy. And certain provocation techniques are used to increase the sensitivity of detection, like sleep deprivation, hyperventilation, and photic stimulation. So on an average, 2% of healthy population can have interictal epileptiform discharges, and this value was derived from EEGs which are done for flight attendants as a routine screening. And if a patient does have a history of seizure and does a routine EEG, then there are just 50% chance, 20 to 50% chance that an IED will be picked up. Whereas the sensitivity can be increased to almost 90% in 3 subsequent EEGs or with sleep deprived EEGs or a longer duration EEG. The next few slides will be focusing on focal interictal epileptiform discharges. So temporal lobe epilepsy, it is the most common focal epilepsy in adolescents and adults, and they typically originate in the mesial temporal lobe. From a surgical perspective, the presence of contralateral temporal interictal epileptiform discharges is associated with generally a less favorable surgical outcome post-temporal lobectomy. So in this montage, you can see that there are left temporal epileptic spikes. Now coming to frontal lobe epilepsy, interictal epileptiform discharges are less frequent. They do tend to localize well to the frontal lobe, but they are difficult to lateralize. The maximal negativity is over the frontotemporal region, the frontotemporal region, and the anterior midline regions. So here we can see that there are bifrontal spike waves which are seen. Right are more than left in amplitude. Coming to centrotemporal spikes. So childhood epilepsy with centrotemporal spikes, Rolandic epilepsy, are the most common focal epilepsy syndrome of childhood. The seizure duration age group is between 3 and 14 years of age, and most children generally outgrow it by 16 years. Focal sensorimotor seizures that start in the face or arm during sleep and may secondarily generalize. The spikes which are observed over the centrotemporal region may be unilateral or bilateral. So we can see a montage here of centrotemporal spikes. So this is another montage of a child in an awake state with an alpha background showing left-sided centrotemporal spikes. So it is benign epilepsy with centrotemporal spikes. What do we mean by benign? So there is preservation of background activity on EEG, even with dramatic epileptiform discharges, and generally neurocognition is not significantly affected and are usually self-limited. The same child here, when he is asleep, we can see that the frequency of this interictal discharges have increased, and also now they have become bilateral. From left, they have also gone to the right. Coming to occipital spikes, they are frequently observed in childhood occipital epilepsies, namely Panayotopoulos and Gaston types. They are associated with autonomic symptoms such as emesis, pallor, cardiorespiratory irregularities, ictal headaches, visual hallucinations, etc. Occipital spikes may also be observed in patients without a history of seizures, like patients who are congenitally blind may also have occipital spikes present, which might be normal. So this is an EEG montage showing left occipital rhythmic periodic occipital spikes on the right-hand side. So the lady here had an encephalomalacia which was detected on the CT, which I have not shown. So these are runs of spike waves which are seen in benign epilepsy with occipital paroxysms. We can see that these waves are present when the eyes are closed, whereas they're absent when the eyes are open. So this can also be labeled as station of sensitivity. So coming to temporal intermittent rhythmic delta activity or TIDA, we can see that here there are right-sided rhythmic theta waves which are seen with a frequency of 1.5 to 2 Hertz. And this is another example of TIDA, but this time it is a left-sided theta activity. Sorry, I meant delta activity. So coming to TIDA, they are unilateral intermittent rhythmic sinusoidal or sawtooth activity of 1 to 4 Hertz. The clinical significance is that concomitant depth and scalp electrode recordings have shown that TIDA correlates with intracranially recorded mesial temporal spikes, and hence is therefore considered an EEG marker for mesial temporal lobe epilepsy. In the next few slides, we'll be seeing generalized interictal epileptiform discharges. They are divided into spike and slow waves and paroxysmal fast activity. We use the term fast activity when it is more than 4 Hertz generally. So coming to generalized spike and slow waves, they are bilaterally synchronous spikes which are followed by a slow wave of high amplitude. They generally tend to have a frontal predominance, and they are consistent with the diagnosis of generalized epilepsy. Two such classical syndromes are childhood absence epilepsy and juvenile myoclonic epilepsy. So here we can see that there is generalized paroxysm of spike and slow wave discharges. Coming to absence epilepsy, they are generally 3 Hertz in frequency and spike and slow wave discharges. They are present lasting from 1 to 3 seconds, and they're activated by hyperventilation or hypoglycemia. So clinically, we can use this in a patient to distinguish them from complex partial seizures, is that we ask the patient to breathe in, count 1, breathe out, breathe in, count 2, breathe out. So those patients who have absence epilepsy may not be able to maintain a track of their counting accurately. So if the discharges last longer than 6 seconds, then they're associated with an alteration of consciousness and are considered as ictal discharges. So here we use the term microabsence, which is generally said that if the absence epilepsy is present on an EEG from 6 to 10 seconds, then there is more than 6 to 10 seconds, then there is an alteration in consciousness. So here we can see childhood absence seizures, where there is a rhythmic generalized single spike and wave pattern. Initially, the frequency is more, but as it progresses, it becomes a frequency of 3 Hertz, and it generally tapers down to 2.5 Hertz and ends. So this is a montage of rhythmic polyspike and wave appearance, which is classical of juvenile absence seizures. Coming to myoclonic seizures, juvenile myoclonic epilepsy is a common generalized epilepsy syndrome. Generalized spike and slow wave discharges often occur at a faster frequency, typically from 4 to 6 Hertz in the syndrome. And generalized polyspikes can also be seen. JME is often associated with a photoparoxysmal response, whereby photic stimulation can elicit a bilateral synchronous spike and slow wave during or outlasting the photic stimulation train. So here we can see a generalized paroxysm of spike discharge, which is associated with the myoclonic jog. Coming to generalized paroxysmal fast activity, it is frequently observed in NREM sleep, and it typically lasts from 2 to 4 seconds. It is traditionally associated with epileptic encephalopathy with intellectual disability. One such syndrome is Lennox-Gastaut syndrome. In this montage, we can see the paroxysmal activity of generalized fast waves. If on this EEG the amplitude were to be reduced, then we would see that the frequency lies somewhere in the beta range. Now coming to description of focal seizures. Mesial temporal lobe epilepsy. So mesial temporal sclerosis present with clinical features of visceral sensations and automatisms. And they are the most common focal seizure disorders in adults. They are rhythmic, sharply contoured temporal theta activity, which appear within 30 seconds of seizure onset. Neocortical temporal seizures are also seen. They're usually shorter in duration and have clinical features of auditory hallucinations. These neocortical temporal seizures often evolve into unilateral clonic activity or generalized seizures, and this generalization is more common in neocortical than mesial temporal sclerosis. So this is a montage of a patient who is having generalized theta activity present on the mesial temporal side, and this has increased in frequency as the seizure is progressing. And here we can see that it has also generalized to the parasagittal area now. Coming
Aditya.
to yes, ma'am.
Yeah, that was focal onset. One more slide. Go back. But there. It is a focal onset on the left temporal region, not generalized. Focal theta activity. Okay. Focal rhythmic theta on the left temporal. Next slide. Evolving further, faster in frequency. Now, yeah, the entire left temporal chain is involved, and then the subsequent slide, the left parasagittal region is involved. At this time, a patient in CPS due to mesial temporal epilepsy develops the contralateral dystonic posturing, but there is no generalization.
Sorry.
That's all. Yeah.
So coming to frontal lobe seizures, it is the second most common focal seizure, and they are less likely to show localized onsets. The causes are first, inaccessibility to much of the frontal lobes to the surface electrodes, and the second, widespread anatomic connection of the frontal lobes to other areas, and the orientation of the dipoles. And they have paroxysmal fast activity and generalized background attenuation. So this is an EEG montage showing low attenuated spikes which are generalized in the frontal lobe, and this has progressed into a seizure which is having multiple muscle artifacts. And in this montage we can see that there is background attenuation and muscle artifacts which is secondary to the hypermotor activity of the frontal lobe seizure. Occipital lobe seizures are generally less common, and paroxysmal fast activity or fast spiking or both in the occipital regions with occasional gradual and anterior propagation and generalization can be seen. So in this case, you can see the occipital spikes on the left-hand side, and these are the eyelid closing artifacts. So the same patient, the occipital lobe spike has become rhythmic and has increased in frequency and amplitude. So coming to generalized ictal seizures, they were classified into two types: electro decrement pattern and spike and slow wave discharges. We have already seen the examples of JME and absence seizures. So we'll just talk about the electro decrement pattern. There is sudden attenuation of amplitude for a few seconds, and the electro decrement pattern may be preceded by a diffuse sharp and slow wave. There is generalized low voltage fast activity, which is often superimposed on the electro decrement. This pattern is mostly observed in tonic and atonic seizures, as well as in epileptic spasms in infants. So here we can see a paroxysmal burst of spike and slow wave followed by an electro decrement pattern, which is superimposed by muscle artifact because of the tonic posturing of the patient. Coming to periodic discharges, they are again of two types, generalized and lateralized. So periodic lateralized epileptiform discharges or PLEDs, they are commonly seen in acute destructive brain injury, such as herpes encephalitis and stroke. They emerge after focal status epilepticus as well, and it is a transient phenomenon that rarely persists for more than a few weeks. Here we can see the right-sided rhythmic lateralized periodic discharges, which are seen, called as PLEDs. So generalized periodic discharges, they are seen in systemic metabolic derangements, sometimes in CNS infections as well, and in post-anoxic brain injury, when associated with myoclonus, they represent the electrographic correlate of a myoclonic status epilepticus. And if we observe this in a patient, then it generally implies that there is poor prognosis for that patient. So this is an example of a generalized periodic discharges, which are rhythmic and well seen. Coming to triphasic waves, these are high amplitude positive transients that are preceded and followed by negative waves of relatively lower amplitude. They can be singly seen or unilaterally seen, and they are generally a hallmark of hepatic encephalopathy. But they are also seen in toxic encephalopathy and metabolic derangements or structural changes. So we can see here that this EEG montage is strewn with triphasic waves, which can be seen. So the take-home points: a single routine EEG has low sensitivity for detection of interictal epileptiform discharges, that is only 20 to 50% for patients with epilepsy. This sensitivity can be increased by repeating the study. So you can repeat it by recording for a longer period of time, such as overnight, by including a recording of sleep, which can be spontaneous or after sleep deprivation or via administration of a sedative. Or we can perform the EEG within 24 hours of a seizure, and you can use special electrodes like the intracranial electrodes for temporal lobe epilepsy. A normal EEG can never rule out epilepsy. 10 to 20% of patients with definite epilepsy never have interictal epileptiform discharges. The specificity of IEDs for epilepsy is high, more than 90% in adults. However, inexperienced EEG interpreters can mistake artifacts or benign EEG patterns for IEDs and thus lowering the specificity of the study. When to order an EEG? So if we have a definite suspicion of an epileptic event, or it's a first unprovoked seizure, or if there is prolonged unconsciousness after control of status epilepticus, or if there is any suspected pseudoepileptic events. There are several reasons why EEG alone cannot be used to make or refute a specific diagnosis of epilepsy. So it is basically a clinical diagnosis. Most EEG patterns can be caused by a wide variety of different neurological diseases, and many diseases can cause more than one type of EEG pattern. Intermittent EEG changes, including interictal epileptiform discharges, can be infrequent and may not appear during the relatively brief period of routine EEG recording. The EEG can be abnormal in some persons with no or other evidence of disease. When not to order an EEG, just because if you want to rule in or rule out epilepsy, then the sensitivity is very less, 40 to 50%. Or if there are non-epileptic events like breath holding spells, typical febrile seizures, vertigo, or syncope, then there is no need of an EEG. So some provocation techniques that we should remember to increase the sensitivity of detection are sleep deprivation, hyperventilation, and photic stimulation. Thank you for your patient listening. And I'd like to thank Purnima Shah ma'am for guiding me in using the language of EEG in such a short time. Thank you, ma'am.
Aditya, you have presented very well. I would like to say that Aditya has not done his neurophysiology posting yet, but he was very enthusiastic. Can everyone hear me?
Yes.
Yes, sir. Yes, but he has done well. If I have to add just 2 or 3 points, one is that whenever we are doing a EEG, which is an OPD procedure or a planned EEG, it is very good to include sleep. With that, the yield will increase up to 85%, which can be through sleep deprivation, and also we can give oral sedation like pedicloral or melatonin. Additional developments in using EEG is to use polygraphy, like when we have children with infantile spasms, then we can use EMG channels or eye electrodes, and we can actually qualify the event, because these events happen so many times during the day. And even if we add the video into the EEG, then with a 1 hour recording we can qualify the abnormalities in a very good manner. Similarly, for ICU EEGs, what I can add is that it is good to do a 1 hour recording for ICU EEGs, particularly for patients who are not waking up, for drowsiness which is not explained, where infection, metabolic causes have been ruled out. Then the yield of a 1 hour EEG is 50% to diagnose non-convulsive status epilepticus, and it can be increased up to 80% if we do a 24-hour recording, but I know that the cost is prohibitive in our setting. And lastly, that there are hardly any cases, situations where the findings are signature. So the point that he mentioned, that there would be different findings in a particular condition and vice versa. So always it is a clinical correlation. Whenever we are interpreting the EEG, we need the clinical information regarding the patient status, the type of seizure, and so on, to get more value out of the EEG report. Thank you.
Thank you very much. Basically, I've always had this question, that as somebody who sort of works with the EEG, where do you find yourself helping the clinician maximum in your day-to-day work? Which syndromes or which situations again and again you see clinicians missing, which you point out with the EEG?
Sir, in the syndromic identification, it becomes very useful. Yeah. Yes, that is one thing. For whether it is IG. Yes, sir?
Satish will have to define a physician or a neurologist.
Yes. Yeah. So in the, for example, in childhood epilepsies, or even in IGE, so it is very useful for the syndromic identification and classification. In focal epilepsies, in temporal lobe epilepsies, the yield of EEG is very good. I think for the extratemporal, MRI becomes more useful when it is lesional rather than the EEG, because if there is a history of seizure and the EEG comes normal, it becomes a clinical diagnosis. So, and in the ICUs, the EEG, the role of EEG is very, very useful.
Yeah.
For the various situations. Yes, yeah. Yes, sir.
Great. So over this, it has changed from standard diagnosis of epilepsy to specific, more specific. Yeah.
Yes, if we have a good history, which
Great.
we do,
so are there
comments?
The
EEG, then we can definitely include polygraphy and video, which, like, even pseudo seizures now, with a daytime recording of 2 hours also, we are able to get good results in the EEG. It's very valuable then.
That's good to know. Even a 2 hour is good.
Let us move forward.
Yes,
yeah. So let's go on to the last presentation before the two talks come up. Hiral Halani non-epileptic episodic event, and Hiral is doing it with me. Yeah. Hiral?
Yes, sir. The slides are visible.
Slides are visible. Also turn your video.
Yes, sir. So hello everyone. Now I'll be discussing about non-epileptic events. So what are these? The non-epileptic events, episodic events are defined as paroxysmal events characterized by either changes in behavior, experience, sensation, or movement that can resemble seizures. Now the term non-epileptic is being used often interchangeably with psychogenic non-epileptic seizures, but it is not so. Non-epileptic events can be classified into either physiologic or psychogenic. Now, again, physiologic can be neurologic, like TIAs, migraine, sleep disorders, movement disorders, or non-neurologic, like cardiac or toxic. And the syncope falls kind of in between. The mechanisms are neurocardiogenic, as explained. Psychogenic can be multifactorial. Now, as Katrak sir mentioned early on, that we have to go back to our grandfather. So, as Gavar said, in very early on, he has described these kind of events in his book Borderlines of Epilepsy, in which he mentioned some intermittent paroxysmal disorders which mimic seizures, and they were for a very long time they were being misdiagnosed as epilepsy. So he has included in that the events of faints, meaning syncope and vagal attacks, migraine and epilepsy, vertigo, sleep disorders, and psychogenic seizures.
Hiral, I think Gawa would be your great grandfather.
Yes.
Actually, incidentally, for some of those who don't know, Sir Arthur Conan Doyle took inspiration from William Gower's rounds and his clinical acumen to design the character of Sherlock Holmes. Yeah.
Okay. So in our situation, most common situation we face is to differentiate syncope versus seizure. And most of the time our diagnosis remains as query seizure versus syncope. So as we know that the vasovagal syncope, usually they have some prodromal or aura phase, which includes signs of extreme weakness, fatigue, lightheadedness, blurring of vision, and then the loss of consciousness occurs, which will be for shorter duration, and then gradual transition to the post syncopal period, which again includes fatigue and weakness and all. But though we used to differentiate syncope and seizure by that table, but actually no feature is absolute to differentiate these two. As we know that in arrhythmogenic syncope, it doesn't have any relation to posture. It can happen in any other posture than upright posture. Many a time in syncope, patients do not get warning the syncopes. Like usually they describe this kind of pre-syncopal period, but they may not get any warning symptoms. The loss of consciousness can vary from seconds to minutes if there is a prolonged cerebral hypoperfusion. Also, sometimes there can be urinary incontinence in the syncope as well. And when there is a severe cerebral hypoperfusion, and when it reaches the anoxic threshold, and then it can transform into even tonic-clonic convulsion type of movements, which is called convulsive syncope. So there is really difficult differentiation between the two, syncope and seizures. The only thing we can consider is that in syncope there will be a pale ashen appearance of skin with profuse diaphoresis, whereas in seizure the appearance will be little cyanosed and there will be a dusky tint to the skin. Also, another similar condition is hyperventilation spells, in which their patient complains of acral tingling sensation and tetanoid spasms. Another condition to differentiate from seizure is TIAs. Now, TIA is usually patient present with more of a negative symptoms like numbness, paresis, loss of vision, much more than the positive symptoms like sensory phenomena, paresthesias, which are common in focal sensory seizures. The duration of TIAs are usually longer, few minutes to hours, less than 1 hour most of the time, whereas seizure will be a shorter. Another important point to include is the level of consciousness. Now, the loss of consciousness favors seizure over a stroke. Also in TIAs, if we are considering isolated vertigo or syncope as TIA, then there should be, usually we should find some other features of brainstem ischemia, because isolated vertigo, unless they are not associated with other definite brainstem signs and symptoms, the TIA is a rare possibility, less likely possibility. Also, we should consider other medical history, age, and vascular risk factors of the patient to call it a TIA. But again, there are some atypical presentation like limb shaking TIA, which is seen in the internal keratoid stenotic occlusive diseases. Here, the clue is that the movement starts when the patient assumes upright position or whenever there is a hypotension. Also, acute stroke sometimes can present with acute chorioathetoid movements or hemibellismus and subthalamus and basal ganglia stroke. Another condition is amyloid spells. Amyloid spells are described in around 20% of patients with cerebral amyloid angiopathy, in which they develop recurrent focal neurological events, which can sometimes harbinger a future intracranial hemorrhage because of the amyloid angiopathy. So these are also recurrent TIAs kind of event.
Hiren?
Yes.
I think you should make a mention here of limb shaking TIAs, which become a very close differential diagnosis of focal epilepsy.
Yes, sir.
I think it's conspicuous by its absence.
Yes. The next condition we found difficult to differentiate from seizure is migraine. So recently only one patient was there in SIR's OPD, a young female which came with some odd visual phenomena, and then that's when SIR asked us to look up the differences between the visual aura of migraine and focal seizures. So usually the visual aura of migraine, the patient described it as zigzag lines and mainly monochromatic. There also the duration is different. The duration will be longer, around 5 to 20 minutes of aura, and it will be seen as gradually evolving and traversing around across the visual field. Also, it's been described as marching scintillating scotoma, and then which will be followed by additional aura like marching paresthesias. So this duration, this marching phenomena, and the monochromatic, these are the mainly differentiating points for visual aura of migraine, whereas focal seizures, which will be like elementary visual hallucinations, which are these are circles, squares, or sparkling dots, and they will be multicolored, which is important. They begin in one hemifield, but they spread quickly to contralateral field. And there can be sometimes associated subtle movements like eyelid fluttering or frequent blinking, staring look, or other automatism. So we found out these differences, and then Sir said the exactly similar thing, which I found in the Gavar's book, that migraine and epilepsy, though we tried to differentiate these two conditions, but they can be different outcomes of similar phenomena. Because as we know that for migraine, the pathology is Leo's cortical spreading depression, which has been compared with the hypersynchronous cortical discharges of epilepsy. So it is very likely that they share many features among them. Also, the basic pathology between these two is altered brain excitability, plus or minus some role of environmental and genetic factors. So they sometimes can coexist also. For example, congenital epilepsy with occipital paroxysms and benign Rolandic epilepsy patients can have coexisting migraine. Also, sometimes EEG can be confusing and misguiding. As in classic aura of migraine, sometimes EEG can show delta slowing, and even sometimes classic spike in wave pattern also we can get. Also, we use anti-epileptic drugs in the treatment of migraine, and there is also possibility of shared genetic possibility. So it is very likely that these can present as very similar clinical features. The another two confusing conditions are transient global amnesia versus transient epileptic amnesia. So transient global amnesia will be for a longer duration. It will be for few hours, and then patient will have amnesia for that period of time. But though he will be functionally normal for that period, because there is a preservation of working memory, and then after the episode is over, he'll forget about that period of time. And the frequency of TGI is very less. The episodes are widely spaced and they are infrequent, whereas transient epileptic amnesia episodes are brief and recurrent. Also, some form of seizures can have very unusual manifestation. For example, frontal lobe seizures. They will have bizarre, wide, proximal limb movements, axial limb movements, hypermotor seizures. So this can be very well mistaken for the psychogenic seizures. Wherever children present with this kind of events, paroxysmal events, we should first rule out reflux disorder, night terrors, breath holding spells. Now, for the geriatric population, there are some geriatric seizure mimics. So, very often we face this situation that an elderly patient comes with either a drop attack or either blackout, which is brief period of unawareness or visual loss or memory loss, or either a staring looks or either episodic memory loss. So, for all of this situation, we should consider whenever there is loss of consciousness, the possibility of syncope and seizures. Without loss of consciousness, again, TIAs, rarely bilateral ACA-treated ischemia can cause this kind of drop attack. And sometimes this kind of drop attacks can be seen as a warning symptom of progressive basilar artery thrombosis. But overall, as we saw earlier, VBI, unless associated with other brainstem signs and symptoms, is a rare diagnosis. Sometimes drop attacks can happen in third ventricular and posterior fossa tumors, autolytic crisis, and cataplexy. So these things should be kept in mind in geriatric patients coming with sudden drop attack. Now, before moving to psychogenic non-epileptic event, I would like to show one video that, which was a patient admitted with us a year or two back. She was a young female, 15-year female, and she came with basically repeated episodes of vomiting. So we were diagnosing it as a cyclic vomiting versus abdominal migraine or epileptic phenomena. So then we did video EEG. So first I will show the video. It's visible, sir?
Yeah, it's visible.
Yes.
So this is the girl, video EEG monitoring is on. This is just before the episode. She was talking to her mother. So as you can see, she is trying to induce the vomiting, which we were not aware of earlier, but which then we later on find it on the video EEG. Then the mother comes and presses the button. But during the EEG, around this time, we did not find any of the epileptic form discharges. There were eye opening, the eyelid fluttering was seen, patient was awake, there were artifacts, but no epileptic form discharges actually we could find.
Okay. Actually, then when we studied the case further, it turned out that she had anorexia nervosa, and she was inducing this vomiting so that she could stay thin. And another very funny thing happened, Riddhi will remember. When this girl finished her video and everything, and she came down to my clinic, she saw one of her, a person whom she wanted to be like an actress. So she ran after her, took her signature. And believe me, this is about 2.5 years now. She's not had a trouble with anorexia nervosa. She's not had vomiting. So I don't know whether our counseling worked, our treatment worked, or her meeting her Ideal actress worked.
I think the
But
actress.
she was cured. Yeah. So something worked. Yeah.
I think she must have realized that you were treating that actress and then you were treating her. So I think therefore your counseling worked much better.
Possible. Yeah.
Otherwise, this cyclic vomiting syndromes in pediatric have been explained along with abdominal migraine and epilepsy. This kind of generate a spectrum of diseases. So now we'll move towards the main discussion part, that is psychogenic non-epileptic events. So how do we describe them? So these are paroxysmal episodes of altered awareness, movement, or sensation, and can also be extended to include changes in behavioral, cognitive processing, and autonomic function that mimic epileptic seizures, but are not associated with concomitant epileptiform abnormalities on age. So the prevalence of psychogenic seizures are 5 to 30 per 100,000 patients. Females are more affected than males. They have mentioned that psychogenic events constitute 20% of the outpatient at epilepsy center and 1/3 of the inpatients. But this data is from tertiary epilepsy centers, so not very reliable, because they must be getting the refractory seizure patients which are not responding to the optimal drugs. But still, it makes it a diagnosis of inclusion rather than exclusion. And even though there is an average delay of diagnosis for 7 years before the diagnosis. So grossly, how can we differentiate psychogenic versus true seizures? So here the medical history of the patient and the clinical description of events, both are equally important. No single sign can differentiate these two. So when to suspect? Usually when there is very high frequency of the events, longer duration of episodes, and when these are not responding to optimal anti-seizure medication with adequate dosages, then one can think of psychogenic events. Also, when when episodes occur in sleep, it favors a true seizure. In wakeful state, one might think of a psychogenic possibility as well. Comorbid psychiatric illnesses are known to be present in both true and psychogenic seizures. So mere presence of psychiatric illness in a patient should not make us diagnose it as a psychogenic event. The stress factor is evident. The stress factor is usually present in both true and psychogenic. So this cannot differentiate these two. Also, we have impression that the psychogenic events will be a non-stereotypic event, that they lack consistency in their events with one another, but that is also not necessary. There can be stereotypical events every time also. And on top of that, 10% of psychogenic non-epileptic seizures can have associated epilepsy also. So it makes it very difficult to diagnose. But still, we can make some simple points as to differentiate these two. True seizures will be having abrupt onset, gradual termination, and slow recovery, whereas psychogenic will be having opposite, slower and gradual onset, and they stop abruptly, or they can be a fluctuating waxing waning course. Stereotypy is usually present in true seizures, may or may not be present in psychogenic seizures. Duration, true seizure is shorter, psychogenic is longer, for minutes to hours sometimes. Occurrence in sleep, true seizure. Precipitants are common in both. Eyes, this can give us an important clue that eyes are usually open in true seizures and often closed in psychogenic ones, and when we try to open the eyes, they show some resistance to opening. Mouth is open in true seizures and it is shut and clenched in psychogenic seizures. The tongue bites more in true seizures and on the lateral border of tongue, but they can sometimes happen in psychogenic seizures and usually on the tip of the tongue. Unilateral head turning favors seizure. Whole body rigidity is again true seizure. Now the movements in psychogenic seizure are very complex and asynchronous body movements. They are complex in terms of bicycling, pedaling, pelvic thrusting, opistotonic posturing sometimes. So these suggest psychogenic, favors psychogenic seizure, but again, as we discussed, the frontal lobe seizures can very well have all of these complex movements. The responsiveness in true seizure is absent, psychogenic it is preserved, and patient may even recollect all the events. In psychogenic seizure, hyperventilation is common, whereas true seizure will be having apnea sometimes. ictal vocalization in true seizure will be primitive and monotonous, where it will be whereas it will be very well articulated in psychogenic seizures. Ictal crying, stuttering favors psychogenic. Stertorous breathing, again true seizure. Ictal tachycardia, urinary incontinence, prolonged flaccidity, and injuries all are common in true seizures, absent in psychogenic seizures. There's been one semiological classification also suggested for this psychogenic non-epileptic seizures. They can be either dystonic seizures with primitive gestural automatism. Sometimes they can be paucikinetic attack with or without preserved responsiveness, in which there are low amplitude lip movements, kind of fine rhythmic tremor types. Otherwise, there can be hyperkinetic prolonged attacks in which there is wide amplitude movements of trunk, limbs, hyperventilation, etc. Or some of them can be pseudo-syncope or coma-like episodes. They are abrupt, short, and patient will be unresponsive, silent, and motionless, lying motionless. Other is axial dystonic seizures, and the some are unclassified. So how do we diagnose? Now we can call it a possible diagnosis when we have detailed clinical history and identification of a comorbid condition which is found to be related, some psychiatric illness, some childhood post-traumatic stress disorder, or history of some childhood abuse. That can lead us to possible diagnosis. Now, when we have actually reviewed the clinical event in video or in person, we can call it a probable diagnosis, where both of these should have normal interictal EEG. Whereas for confirmed and documented diagnosis, we need video EEG monitoring for sure. Now, the pathomechanism. So the mechanisms underlying these psychogenic events are multifactorial. They have been linked with psychiatric illness, neurological conditions, and environmental factors. But before understanding the mechanism, we should know that we cannot clearly differentiate the psychogenic and physiologic mechanism from each other, because all pains have both components, psychological and physiological. You can never really differentiate or attribute one component as a whole. Psychogenic event is not an imaginary problem or malingering. As sir always says that they are also suffering, so they are not malingering. So what makes them suffering? So the few mechanisms have been explained underlying this psychogenic non-epileptic seizures. Most common is dissociation. Now, dissociation simply means disintegration of mental functions. That means disruption of integration between consciousness, that is responsiveness and awareness, memory, identity, perception, and emotion. So these all cognitive functions are kind of disintegrated in the dissociative disorders. Next is somatization, which means distortion in one's own body perception or either heightened awareness of some somatic symptoms. Then the next mechanism explained is very interesting. That is a narrow window of arousal tolerance and attentional bias. So by this, we mean that attentional bias means that two different attentional behavior. Usually people have two different attentional behavior. One, at one end, the people will be behaving neglected or very much distractibility or suggestibility. And on the other spectrum, they will be either very much focused or very much focused, excessive attention, and the extreme spectrum of this is obsession and compulsion. So we usually, as a normal individual, kind of make a balance between these two extreme attentional behavior. And when this balance is impaired, they fluctuate between their responses. That is hyperarousal responses and hyperarousal responses. So hyperarousal responses meaning hypervigilance, hyperactivity, autonomic arousal, or anxiety and panic attacks, whereas opposite is hypoarousal. So these patients, they have a very narrow window of arousal tolerance, and they oscillate between these two kind of responses, which generate the abnormal behaviors. Another mechanism is alexithymia. The word alexithymia means inability to express inner psychic stress or inner emotion. This is inability to verbally express the inner psychic stress, and then this inner psychic stress builds up, and then they will be it will be expressed as physiological reaction as opposed to feelings. So it will create again abnormal behavior. The next mechanism is automaticity, in which there is a disconnection between sensory motor behavior and a sense of volition. So then behavior becomes autonomous and not volitional. So it is now not under our control. It has become autonomous. So all of this creates a very unstable emotional cognitive system, which means that there is disintegration of several cognitive and sensory motor processing. So the sensory motor behaviors have become autonomous, and the behaviors and there are some autonomous pre-wired responses, which we see as psychogenic non-epileptic seizures. So this was a bit complicated mechanism, but to simplify, what we can measure to differentiate is some serological markers. Serum prolactin, which we all know that it rises in a true seizure in the first 10 to 20 minutes, usually twice the baseline value. But you can get false negative serum prolactin in frontal lobe seizures, in status epilepticus, and when the patient is on dopamine agonist. False positive results with the dopamine antagonist. Venous psychogenic events, psychogenic patients can have elevated basal cortisol level. CPK and other neurotrophic factors have limited value in diagnosing. We should do neuropsychological testing also to identify the underlying psychological triggers, as usually they have depression, anxiety, and like disorders. Neuroimaging do not help to differentiate between psychogenic and true seizures. But on functional imaging, there have been mentioned that there is abnormality in brain connectivity, and they have mentioned that there is a dysfunction at the level of medial prefrontal regions and the anterior cingulate gyrus, which might mediate much of the instability observed in these patients. So now the most important part is disclosing the diagnosis. Now, simply telling the patient that you do not have epilepsy will be like a negative diagnosis, and it will create a negative impact on them. So rather than, we should tell them what they have, not that what they do not have. So we should explain them that these are sort of seizure episodes, fortunately not epileptic. And here also they have suggested that the word seizure should be used instead of attack or event, because the attack or event, these words might again trigger some memories of their past events or past traumatic events, and then again precipitate or reinforce such episodes. So we should be very careful with our language in these patients. We should explain them that they are multifactorial and the disorder is real and should be taken seriously, and that there will be a comprehensive and unified approach to the treatment. So most important is accepting the diagnosis. And another important thing is that we should always offer them a follow-up, because we, in our mind, once we find a psychiatric component attached to any disease, we kind of take it in a lighter or ignorant manner. But not offering a follow-up to them will make them feel abandoned, and there will be loss to compliance, and then the treatment suffers. The last part is treatment. Psychotherapy, appropriate psychiatric referral and counseling should be done because of the comorbid psychiatric illnesses. The most efficient therapy is cognitive behavioral therapy. And the basis of CBT is to learn to increase awareness of their dysfunctional thoughts and develop new behavioral responses. And the trials have shown more than 50% reduction in seizure frequency with CBT only. There is some investigational use of sertraline, which is a serotonin reuptake inhibitor, in psychogenic events, but the studies are very small, and it's still in off-label use for these patients. Again, the higher education, shorter time to diagnosis, and lower somatoform and dissociative scores may predict better outcomes. So thank you.
Thank you, Hiral. Thank you very much. I think you covered it very nicely. It's a large topic and it's a difficult topic. So I'll make one or two comments since I was involved in the preparation. Basically, I think these diseases are quite complex, and sometimes the borderlands are such that you, in spite of doing everything that you cannot make up your mind as to what the illness is. And this holds true between syncope and a seizure also, and epileptic and non-epileptic also. So I think generally, the simpler the patient, simpler it is to make the distinction. More complicated, more intelligent the patient, more difficult it is to make the diagnosis. So I think that also plays a role in how they are looking at it and how they allow you to look at it. So I think it's a very complex interaction. Also, leaving the door open, I think I have found it very, very useful. Just allowing them to come back to me and say whatever they feel like saying seems to help them. Sometimes you feel in your own mind, this is like a pilgrimage. They are coming to the temple, going back, but it seems to help them. Even if you can't do anything, you seem to be able to help them. So I think not disposing them off that you don't have a neurological problem, but allowing them to come and talk to you also helps them. And lastly, I would like to know the experience of all the senior people here as to how do they put up the diagnosis. I have found it a difficult issue. Different things work for different people. I've generally started telling them that this is something at the junction of the mind and the body, which I also don't understand and they also don't understand. It seems to help them. But I don't know how you all tackle this, giving out the diagnosis.
What I tell them is that what you have is something terrible and devastating. It means a certain degree of loss of income. They sympathize with that. When you tell them that you're feeling very bad, that they're losing some income, losing some status, losing some, going out to Kulu Manali and Kashmir becomes difficult because you have it in a train, then nobody can take care of you. And that sort of thing helps them a lot. And you feel good that somebody's feeling bad for them. And then I tell them that as yet, there doesn't appear to be a brain tumor. They like that. If you don't have a brain tumor, they're quite happy about it. Because I invariably had 2 or 3 scans before they come and see you. You don't have a brain tumor or a stroke or a paralytic attack. And as long as you don't smoke, drink, and take care of your blood pressure and lipids and diabetes, you're not likely to get it right now because you're young. So, and then we'll start this treatment. And if there is a problem, just try and be safe and take rest. And don't get involved in a rush. Don't get phoning up and don't get very aggressive about your business deals or whatever. Just go inside and take rest. And that may be a better off. So when they start doing something, they tend to collapse and then they get an audience. So take them away from the audience. I try and get them away from the audience.
So that's for the malingerers or those, those who put up a show.
They just love all that.
Yeah. Dr. Praveena Shah is here. Ma'am, good noon. Thanks for joining. Ma'am, are you there? You're on mute and... So I think by the time we have comments from Dr. Praveena Shah, Dr. Khan and Dr. Katrak.
I'm there.
Can I
I'm
request?
traveling, so...
Okay, yeah. No, I was just going to request the audience to fill up the forms by the time this is going on, so that we have your comments on. So please fill up the form that Azad has sent in the minute. It doesn't take even a minute. So, ma'am, sorry, yeah. Please tell about how you tackle the non-epileptic event people.
I think, as you rightly said, it depends on a patient, her circumstances, her family. You have to really go into the details, especially if it's a married woman.
Praveena,
yeah,
it is not restricted to the female sex.
Pardon?
It is not restricted to female sex, so please don't keep saying no.
Correct. I know that. But if suppose it's a married woman and there are in-laws along with her, I think you have to be very careful in, making the understand. Don't use the word hysterical or psychological very easily. It's very important.
No, I think what was mentioned that you use the word seizure, but say it is not mirgi. It's a different type of seizure.
Yeah.
So you're actually bowling a googly.
Correct.
And I think sometimes in medicine, telling white lies is possible in the interest of the patient. Management.
So that way seizure is such a safe word.
I know.
The patient is being seized by what we are not saying.
And you have to inform this is not because of a Kali Devi or ghost or this and that.
Yeah.
So all black magic and all that sort of thing also you have to clarify.
Yeah. I mean, just a general comment, not limited to these people with non-epileptic seizure events. Most of my senior patients are very happy when I tell them that they don't have anything big and they can go home and be okay. But most of my younger patients become very unhappy when I tell them that there is nothing. You have to tell them something. Little cervical spondylosis, little migraine, little this, little that. I think the modern Indian has to feel slightly unhappy to feel happy.
No, they want paisa vasool.
Paisa vasool. I was just
wondering that you charge. If you say there's nothing, what the hell am I paying you for?
Yeah.
At the same time, a senior patient appreciates it. I think it has got something to do with the age and the way life is, because senior people don't want to be told that you have this and you have that.
No. You have to tell them it's not the big C. Cancer related.
Yes.
That is why senior people love to hear that,
Yeah. Also, I think in the differential diagnosis, the last thing I want to say is that follow-up is very important. Because sometimes as time goes by, something becomes more clear than at the first go. So even if you can't make a diagnosis at the first go, it's still okay. It's much safer that way.
As I say very often, sometimes time is the best investigation.
Correct.
Absolutely.
You have to be very careful when it's a mixed epilepsy.
Correct. Ma'am, in your vast epilepsy experience, how many epileptics additionally have these social benefit events?
Actually, Satish, I'm traveling, so not able to hear properly.
No, I was asking, amongst the group of genuinely epileptic individuals, how many end up realizing that the attacks have advantages and then start feigning them as well? I mean, that's crudely putting it. Yeah.
Yes, there are few people like that. Because it gives them a sympathy by the family.
In school children, I find that very common.
Yeah, not common, but there are.
I will put it, Satish, it depends on the control of epilepsy. Patients with refractory epilepsy tend to have more of this. And sometimes it becomes very difficult to separate the seed from the shaft.
Yeah.
Whereas if it's a early onset or a fresh onset epilepsy with a structural lesion and they are well controlled, I don't think they have much of a psychological overlap.
Correct. So it's more with the chronic and uncontrolled.
More with the chronic epilepsy.
Yeah.
Because with chronic epilepsy is associated depression and many other thoughts.
Yeah. Does Dr. Khan or Dr. Lalkaka want to make any comments on this topic before we go on? And I hope you all fill your questionnaires.
Not really. No.
Jimmy, anything?
Yeah. No, I think absolutely.
Said.
Sure.
So let's now, Jimmy, you want to you
No, I just
saying?
wanted to say the absolutely fascinating session. All the talks were just too good. The remarks and the things was excellent. I think I've learned so much. Thank you all very much.
We have still got 2 coming, so don't go anywhere. So now there are 2 talks, short talks by 2 very experienced clinicians. Dr. Katharaki is going to talk to us about common issues in the management of epilepsy, his experiences, which will be very interesting. And it will then be followed by the last talk, epilepsy and driving age, current status in India, which is again a very, very important topic, which Dr. Ashok Sirsat will be doing. Sir, can we invite you?
Yeah. I think if you stop your screen.
Yeah.
I can't get the screen share.
Rahul, can you help, please?
The bottom of the screen, there's one share screen, there's a green.
No, I'm not getting the Zoom screen.
Oh.
Satish, can you just close your thing because...
Sir, everyone else is closed, sir. Just now there is no screen being shared.
I can't see to see.
Cursor to the bottom.
Is the Zoom icon?
Wait. Join the meeting.
You're already in the meeting, sir. In the bottom is there a Zoom screen? Is the Zoom icon at the bottom?
Now can you see my slide?
No. No, sir.
Sir, bottom in a green signal, share screen. So once you can click, sir.
Hey, Baba, I'm not getting that screen with the share screen green signal. That is my problem.
Can we switch off everyone's videos?
That is the problem, and now I can't switch this off. I'm getting Jimmy Lal Kaka and screen.
So if you wanted to leave and then join again, it might come.
See, I'm seeing. Can you see me on the screen?
Yes, sir. We can see.
Yes, sir. Yes, sir. Sir, once you can leave the meeting and sir rejoining.
How do I leave the meeting also?
And
because
yeah,
that is not coming.
yes, sir.
Right bottom.
Again. Yes, sir.
Shall we request Dr. Shirsat to do it till that time?
Yeah, please.
Yeah. Ashok, are you okay with that? Ashok?
Yeah, whatever is comfortable to sir, I'm okay with
earlier? Yeah. So let's go ahead.
For the sir has to stop screen sharing.
No, he's not sharing. No, that is the problem.
I can't see.
Bottom of the screen.
Can you see?
This cursor, sir, bring it to the bottom of the screen. Immediately.
1 minute. Just 1 minute.
Cursor, bring it to the bottom of the screen, and you will see the thing coming up. Icons. You'll see a green box, share screen, the red on the right.
I have to leave the meeting, sir.
Now you have left.
Yeah, Ashok, if you wanted to share.
I'm absolutely ready. Can I start?
Yeah, please. You know, in the interest of time, let's do that.
Is it coming on?
No.
Can you guys see something?
No.
Hola.
Rahul, there is something technical. If two people can't, yeah, we can see now.
Yeah, we can see, sir.
Yeah, Ashok, you're on now.
I'm on?
Yes.
Yeah, voice is okay?
Perfect.
Yeah, so since my friend Arjun took a little more than 30 minutes, I'll make it less than 15. I just want to give you salient points. I wish to give the postgraduates who are now protected in a big hospitals like Jaslok, Bombay Hospital, JD Hospital. They're soon going to go out and practice, and the law will be always on the head. The factor of law will always be there. With epilepsy, it's very special. It's a very special sort of disorder where it interacts with the law. We're going to deal with two things: driving and marriage. And driving and marriage in epilepsy, if you want to hold knowledge, you'll have to read 2 volumes. But let us stick to India. Now, why have we selected this topic? Actually, I got a brainwave to when I think there was one topic in this issue on all kinds of things, the difference between the laws in Wisconsin and South Carolina, and how they're different. I said that's totally irrelevant. What's going on in our country is far more important. So we need to know what about these topics if you wish to stay in India and practice India. You want to go to America, please read that chapter and go. But if you want to go and stay in India, and right now you guys are staying in India, practicing in India, treating patients with epilepsy, so better know this topic well. And then why did I say with India? I think we have to accept it. We are different from the rest of the world. Our values are different. The way we do things is different. People sometimes laugh at us, sometimes they don't laugh at us, but that's it. We are different from the rest of the world. We can't say sub-Saharan Africa. We can't say South Asia. It doesn't work. We are all different. Indian, Pakistani, Bangladeshi, even Indians in one country are different. Assamese are different from the Gujaratis, and it's a very, very complex situation. It is of no value to us and our patients to know how the rest of the world manages the problems and how they adapt. We are at least now lucky, and I'm soon going to tell you why. We are at least lucky that we know what do we do with this. We know how to go about this. And for that, we have to thank something called epilepsy and the law in India. You can see on the top left-hand corner, there is the International Bureau of Epilepsy. On the bottom, there are two associations, the Indian Epilepsy Association and the Indian Epilepsy Society. The Indian Epilepsy Association is for the neurologist, by the neurologist, and the Indian Epilepsy Society, everyone is present. Patients, doctors, GPs, pediatricians, you name it and they're there. And patients' parents, they're very, very aggressive. Some patients' parents are very, very aggressive in that. They stand for elections and do well. And so you have to be a little careful when you go there for dinner. You can't go drinking and dancing in another place. So be careful about that. So what are some key points on driving? In driving is defined as motorized two-wheelers, four-wheelers, and trucks. There are laws all over the world and variations exist. What does science tell you? What does science tell you? Roughly, science says if focal epilepsy is due to an old structural lesion and on regular treatment there is no seizures for 6 months, then it is safe to drive. If there is a seizure, stop driving, adjust your dose till you don't have a seizure for 6 months. If the lesion is active, like let's say a glioblastoma multiforme, or let's say active neurocysticercosis, let's say a tuberculoma, then stop driving till the seizure becomes inactive. You got the medicine behind it, the laws. In generalized epilepsies, stop driving on diagnosis and no seizures for 6 months. Whenever the doctor decides to taper, then stop driving till the tapering is done and no seizures in 6 months, they can restart driving. Please remember, every country has different laws. Different states in America have different laws. In Europe, it is 6 months. In Australia, it is 6 months. In Britain, it is 1 year. In America, it is 6 months. So every country has different things, but they have something in black and white. But when you put these laws, it means something. What does it mean? The neurologist has the power to suspend a patient's driving license. If the neurologist says, don't drive, and gives it in writing and types it out on the patient's case file, the patient has to give up the driving license. It is as simple as that. He cannot sit on the wheel even to go home. He has to literally call his family member that please come and pick me up. I'm alone in the neurologist's office. He's told me not to drive. He has given the intimation and I can't drive. Do you think all patients listen to the neurologist? No, they lie, even in the West. They say, Chalta, that's what the stupid doctors told me. Hey, come on, I'm just going here close by. They try and do, but it's not worth it. An accident is not affordable even for the affluent patient. The insurance company will withdraw the cover And in that case, instantaneously it will be a criminal case, because it's very simple for an insurance company to trace the papers, to trace the medicines taken, to see what the Mediclaim people have done. It's very easy. So that's how in the West. But what happens in our own country? In India, in a driving license application, question number 1, have you ever fallen unconscious in your life? Very, very simple question. It can't be very simpler than that. If the answer is yes, then you're not eligible for even a learner's license, which means by law, no Indian PWE meaning person with epilepsy, is allowed to drive any motorized vehicle ever. It is a very, very stringent law. But this law has been passed in 1939. I mean, surely I think we know a little much more about epilepsy since 1939. Surely there are more medicines available, more easy availability of medicine, more easy available to doctors, neurologists, EEG centers. But that's what it is. This law has been passed then and it stands. The Indian Epilepsy Society are making a lot of effort to change it, especially by Dr. Katrak's friend, Dr. H.P. Srinivas. He spent all his time with the police commissioner's office in Bangalore, but so far no progress. The reality is, sab kuch chalta hai. The neurologists are not obliged to report their epilepsy patients on RTO. And certainly, this contributes to accidents in our country. I am sorry to say that hardly any of my patients, only when the wife is there, when I threaten the whole situation of the happiness of the family, that the husband stop driving. If the spouse doesn't come, these fellows don't listen. I'm frightening you even more. On the highway, there's a truck driver who's a patient of mine from Holy Spirit, who's taking 800 milligrams of carbamazepine. He's had no seizures, but he's still driving a truck on the highway. That's the way it is. And this contributes to accidents. What is the next step? What is the situation of epilepsy and marriage in India? Now, from neurology, let's go to algebra. This is recent history. So when you say algebra, epilepsy is brain damage. If anyone disagrees, tell me. Brain damage leads to insanity. Anyone agree or disagree? Therefore, logically, epilepsy is equal to insanity. And since insanity was a valid ground for divorce, therefore, logically, epilepsy was believed to be a valid ground for divorce in this country till December 20, 1999. And please, I repeat, 1999, not 1899. Please remember that. So it is less than 22 years since this law has changed. Less than 22 years, the Indian Constitution believes that epilepsy is not equal to insanity. So please keep that in mind. To repeal this law, the Indian Epilepsy Society has worked day and night. Especially Dr. Pravina Shah and Dr. Katrak will entirely agree with me, the Bombay doctors. They worked very, very hard for many, many, many years. They sacrificed a lot to get this law in place.
Doctor.
Yeah.
Eddie Barucha, Dr. Wadia, Dr.
They
were in the forefront.
Coordinating with ministers, coordinating with secretaries, coordinating with everyone. I mean, it was needless.
Dr. Mani was also important person.
Yeah, these are the people who worked very hard. At this moment, fortunately, thanks to these people, epilepsy is not a valid ground for divorce. If a wife develops epilepsy, you cannot file for divorce, which you could do before 1999.
Trouble is, Ashok.
Yeah.
Epilepsy becomes a deterrent for marriage. So
I'm coming to that. 1 minute. Yeah, this is a slide. Now the next question is it easy for a PWE, a person with epilepsy, especially a lady, and I'm very clear about this, I'm ruthless about this, to get married? The answer is a capital no. It is not easy. So what do you do in your practice? How do I manage these problems? How, I mean, come on, these people come and say, आता ठीक है, हो ठीक है, pitch control मध्ये हाय. औषध बंद करू उद्यापासून? नाही, औषध बंद नाही केलं तर. मग कोण लग्न करणार माझ्याबरोबर? So these are questions we have to manage, we have to handle. How do we go on? Because they're desperate to stop, get married and not mention the epilepsy to the spouse to be. So that's the problem. Yeah. So that's where we are. So this is hard work done by Dr. Yashoda Wakankar and her team in Pune. And slowly she's expanding not only in all over India, but believe me, ladies and gentlemen, even to a neighboring country of Pakistan. And I'll show you evidence in a few slides from now. You had to be on her mailing list, which I am. Every time, every few months, she organizes fairs, boys and girls epilepsy fairs. All these girls are Fitz Mirgi Akdi, Niyantrana, controlled epilepsy patients. If they want to get married, come to this fair. Register your name, you're given a code number. That code number, nobody has access to it except her. If you like a person of obviously of the opposite sex, and then you want to make data, you have to approach a person there who will give you the data, ask that person whether they're interested in meeting you and arrange a meeting, and then you take it from there. This is the main office on top, and that's how this is done. And I mean, I've had a lot of experience with this group, and they're absolutely amazing. I'm so famous there. This is the guy, Mohan Fatak. This is home address. He said, give my home address to any of patients. You know, even if there's not a fair, they'll come, he takes an interview, gets the data, and sees to it that they come for this fair. He'll go to Kolhapur, Solapur, Thana, Dombivali, Pune, whatever it is. It's moving like very fast. Now there is a tip that I want to give you, a note of caution. Normally, if they say yes, the boys and girls say yes, all right, we are ready for marriage. Then they invariably ask, who's the doctor? They say, Dr. Ashok. I said, fine. Then they said, now give me his file, give me the report, give me the CT scan, give me the MRI. I mean, amcha doctor na dakhu. I'll show to our doctors and we'll see. And then if he says yes, then we will marry you. So after a few years, I did not mind this at all. But now I got a little tough after a few bad experiences. I believe that it's the right of the boys to ask for the girls' papers. Mind you, my talk is only for the girls with person with epilepsy. So they have the real problem. If there exists a right of the boys to ask for the girls' papers, and at times take a consultation from neurologists known to them, I have no objection. Can I make it a point now? I just want to test. Does the boys' side, are they willing to show the same courtesy? I said, fine, you give my papers to him, but you do one thing. You get his papers and bring them to me. And there I found a little problem because once or twice they tried to a mentally subnormal individual with epilepsy. They said, we'll try and get him married, he'll improve. And who best to marry with another person with epilepsy? They won't cause any problems to us. So these problems were very, very sad for me. And now after that, I'm being very, very strict about this. Talk to the boy, then I talk to the neurologist, and we move on from there. Now, this is Mrs. Yashoda Wakankar getting the award, Ambassador of Epilepsy from the IB in Manila. And this is the time where the entire Pakistani delegation surrounded her. The women in the delegation were absolutely astounded that such a human being existed. And she told us, they gave us some heartbreaking, hair-raising stories of what happens to epilepsy women in Pakistan. And they've taken the model of this system and they're trying to implement in Pakistan. And there's another slide on the top. And along with him, on the right-hand side, you can see Dr. Katra's best friend.
HV.
Yeah, Dr. H.P. Srinivas and Dr. Katrak appeared for the DM together. And they to study all night together. And they studied together, they registered together, lectured together, studied together, appeared together, passed together, and now having fun together. Yeah, am I right, sir? So,
yes, very much so. And you can see the fun he's having with the glass in hand.
Yes, absolutely. I didn't want to mention it. But you said it. You said it. So, so I'm just standing behind him because I just came to take a photograph. So that's the way it is. Anyway, thank you so much, and I enjoyed making this talk and sharing it with the young people. Thank you very much.
Can you close the screen?
Yeah.
Thank you very much, Ashok. I think it was really very, very useful.
Oh.
Also, just one or two things that I have found.
Yeah.
One is that people often do not tell before marriage.
Oh no.
And then as a neurologist, you have to go to the court.
No.
So it's very important to document well.
Yeah.
Because you will be asked to go to the court.
Not going to tell, don't come and talk to me again. If you're going to tell, I'm going to fight with you. I'm very clear about that.
Yeah.
Once they understand you, where you stand, they take it.
Yeah. Your own notes.
If you hide, it's not going to do. All my hard work is of no value. Your seizures come under control. It's of no value. You are normal. I'm telling you, you're normal.
Can I say something?
Yes, sir.
What happens is that you tell them to declare the epilepsy.
I tell them.
Wait. I tell them to declare the epilepsy.
Yeah.
The next question is, if we declare the epilepsy, the boy will refuse.
Correct.
Hold on.
Huh.
How do you counter that argument?
I'll tell you.
I tell you. What I do, I'm telling you exactly. Yeah. I said, okay, if one guy rejects your daughter, I would request your daughter not to feel upset. Because what happens if she develops diabetes in the future? Will he reject her only for that reason?
You said diabetes as a heart attack.
I said, and there are examples in my own family where I have advised one of my own family members to marry a girl who has epilepsy. That I will look after the epilepsy. And you have to quote a little filmy dialogue, "Main hoon na," which puts a little confidence into them. You know, I said one fellow will reject you, but I believe that there are many good human beings who will accept you for all your faults.
You're 100% correct.
And if you meet up with such a person, grab him with both hands and marry him.
Correct. 10 માણસો ખરાબ છે 10 માણસો ખરાબ છે 11મો સારો છોકરો તારે લગ્ન કરશે. Yes, I tell them straight.
Yeah. But
okay, I think now while the share screen is going on, I'm here.
Yes. And just one sentence. Yeah. I think whenever this sort of liaison is going on, the other side often says, "Can we come and meet you?" It's very important that the person who has the illness should be present at that time.
Yes.
And that you don't speak without the person's presence.
Yes.
Yeah. Sometimes one gets taken in.
No.
Yeah. Right, sir. So the last talk for the day.
I agree on that, Satish. I agree. Yeah. You know?
Correct.
And I have found very often the male coming in, the partner coming in and telling me, "Please don't tell my parents. They are very old-fashioned, but I'm willing to look after this girl."
Yeah. Yes. There are people like that. Many people like that.
Okay. So now taking Ashok, can you stop your video, please?
Yeah. It stopped?
Yeah.
Yeah.
Okay. Now, one second. See, I'm going to talk of some common issues. Just like Ashok talked of some common issues, I'm going to talk about some common issues which are involved. So the plan of the talk is counseling women with epilepsy about conception. Then convulsions in the ICU, effects of anti-epileptic drugs on hepatic enzymes, hepatic metabolism, renal excretion, and effects of anti-epileptic drugs on body weight and skin rash. Okay, so now let's take the present population of India is 1.3 billion. The crude prevalence of epilepsy is about 5.33 per thousand population. and varies from 1.28 in Gujarat to 11.92 in rural Karnataka. Therefore, taking the crude prevalence of 5.33, there are approximately 6.9 million people with epilepsy in India, of which, when they did all that, the registered pregnancy were 3.9 million. Unregistered pregnancy, nobody knows. And even in a study in the US, 50% of all pregnancies were unplanned. So how do you counsel a lady when 50% of the pregnancies are unplanned? It can be done in two methods: preconceptual counseling and counseling during pregnancy. In India, counseling of women with epilepsy is not very common. One must remember that the major organogenesis is in the first trimester, and therefore the ideal time for counseling is preconceptual. What are the general principles of preconception? Re-evaluate the need for anti-epileptic drugs. Choose the most effective anti-epileptic drug for seizure type and allow monotherapy at the lowest effective dose. Change the anti-epileptic drug before conception, not during the first trimester. Monitor unbound or free levels of anti-epileptic drugs, and even in the preconceptual stage, folate supplements are very, very useful at the rate of 0.4 milligram per day. Now, prenatal diagnosis should be done when indicated. Okay. Now, during pregnancy, the general principles are: please avoid valproate exposure in the first trimester. If you have to use valproate, use it at the lowest possible dose only if the benefits clearly outweigh the risk. Request the people to avoid, the woman to avoid smoking. Now, this is getting to be a real problem in the higher strata of society with a lot of peer review pressures. And all over the world, I notice nowadays that women are smoking much more than men. When I go to Australia, I find that women are smoking much more than men. And in India, also in the social circles.
Khar Bandra.
Yeah, social circles. You know, if you are a social animal.
No, on the road.
Okay. Then, if a female is seizure free in the prior 9 months before the pregnancy, there is a 84.92% seizure free during pregnancy. Now, these are all the major congenital malformations. Okay. And most of these major malformations are detected on a prenatal ultrasound or by doing alpha fetoprotein analysis or levels. Now, this is from the registries of Australia, North America, etc., UK, Swedish, Finnish, etc. And if you look at this, the safe drugs are carbamazepine and lamotrigine. And the bad drugs, are phenytoin and of course valproate. Now, the Indian Registry for Epilepsy was initiated in the year 2000. Please remember, it's only 21 years. And several centers recruited. The initial results showed they could complete 553 complete pregnancies. And no further progress was made because of difficulties in follow-up. And therefore, I believe now that this registry no longer exists. And therefore, the data is available from the Kerala Registry of Epilepsy, which is given to me by courtesy of Professor Sanjeev Thomas. The data is from 1998 to the year 2000, and they have a total of 3,100 plus pregnancies. Out of that, completed pregnancies were 2,328, and the major malformations were in 148 pregnancies. The data suggests that dose dependency for all anti-epileptic drugs, including phenobarbital, phenytoin, carbamazepine, and valproate. The highest risk was with polytherapy and with valproate monotherapy in doses above 600 milligrams per day. And they found that there was neurocognitive impairment in the child that is born, and that persisted up to the early teens when the follow-up has ceased. Now, these are how do you counsel? Now, when you get all this previous data, you have a data at level A evidence, level B evidence, level C evidence. You also have confidence interval, odds ratio. But how do you interpret all this scientific data into a language which a lay person can understand? Now let's take this. This is the major congenital malformation, congenital heart, cleft palate, and neural tube defect. And you take the risk. For heart, it is 3 to 6 times higher. For a cleft palate, it is 10 to 14 times higher. And for neural tube defects, it's for 10 to 20% higher. Now, if you tell a young woman who comes to you for counseling, should I get pregnant? If you tell them your risk is 3 to 6 times or 10 to 14 times or 10 to 20 times higher, that poor girl or that poor woman will get totally inhibited from getting pregnant. However, the main question is, what is the percentage of these defects in the general population? That is, meaning women who do not have epilepsy and who do not take anti-epileptic drugs. And there you see, the general population, the risk is 0.5, 0.1, 0.1%. Therefore, if you interpret it, in women with epilepsy, that risk will be 1.5 to 3% for a congenital heart. For a cleft palate, it will be 1 to 1.4%. And for a neural tube defect, it will be 1 to 2%. Put the other way around, therefore the average risk is 1.5 to 3%. That means the success rate is 97 to 98.5%. If you put it in this fashion, any woman will accept the risks. If their husbands are around, I usually tell them that if you are a businessman and you are investing in shares and there's a 97 to 98.5 success rate of that share going up by 200 or 300%, will you buy those shares? And the answer is promptly yes. So they are willing to take this risk. And that is the way one should try and convince this woman and or the couple to go in for pregnancy. Now, you must remember that you must try and keep them either on carbamazepine or lamotrigine. And you must add to this, there is the added benefit of folic acid supplements. All right. So this is the way to counsel women with epilepsy regarding conception. If you put in the second line here, about 3 to 6, 10 to 40, I don't think any woman will be willing to go through this whole experience. Okay. Now, the second topic, we come to convulsions in the ICU. And the first thing, is it a provoked fit? Now, in the ICU, provoked fits are usually commonly because of withdrawal effects in an alcoholic or with an alcoholic binge. There are metabolic derangements like hypoglycemia and hyponatremia due to SIADH. Now, a quick pointer for SIADH is you don't have to do serum osmolarity, urine osmolarity. Just look at the charts. If there is hyponatremia with a normal BUN and creatinine, it is very, very likely that it is due to SIADH. If it is because of pre-renal azotemia, then the BUN and the creatinine are slightly deranged. So a quick pointer is hyponatremia with normal BUN and creatine, suspect SIADH. And lastly, there are many, many drugs which can induce convulsions. So let us go to the clinical scenario. The clinical setting for SIADH is head injury, infections, subarachnoid hemorrhage, rise of intracranial pressure, and rarely it will be small cell lung carcinoma. Now, medications are associated with SIADH. So please take this list down. Amongst the anti-epileptic drugs, the most notorious is carbamazepine and oxcarbazepine. That is why in the earlier days, when a patient came with a head injury and you wanted to give an anti-epileptic drug to prevent convulsions, that is if the loss of consciousness for more than 1 hour, if there was retrograde amnesia, etc., and you suspected that the post-traumatic epilepsy chances were high, and you wanted to give an anti-epileptic drug, we did not give carbamazepine or oxcarbazepine because of fear of producing SIADH and aggravating the convulsions because of hyponatremia. The other drugs I've outlined here, thiazide, vincristine, cyclophosphamide, vasopressin, these are all commonly used drugs. So please go through the list of drugs that the patient is getting if you want to avoid SIADH. Thirdly, there are many drugs which induce convulsions. And look at the list of antibiotics: cephalosporins, fluoroquinolones, carbapenem, antiretroviral drugs, antifungal drugs, and miscellaneous drugs. Chemotherapeutic agents, antiemetic agents, which are so frequently used in the ICU, particularly by the medical oncologists. Immunosuppressants, respiratory drugs, recreational drugs, and muscle relaxants, and other drugs used in pain management, weight loss, and psychotropics. So I think you have to go through the list of drugs and be aware that there are many drugs which can produce convulsions. Now, this is a slide I show frequently in my talk of drug-induced seizures and coma, and you can see cephalosporins produce seizures as well as non-convulsive status epilepticus. And the risk factors are there in elderly with mild renal failure, prior CNS disease, and hepatic failure in the case of metronidazole. And cefepime is the only drug which can also produce a coma. So you can get seizures first and then the patient goes into a coma. Please look at the drug cefepime. Fine. Now, the third part is the effect of anti-epileptic drugs on hepatic enzymes. And let me say that most of the clinical relevant drug interactions are affecting drug metabolism. The majority of the first generation drugs, which are inducers, are metabolized by the cytochrome P450 hepatic enzyme system. Therefore, there are drug inducers, hepatic enzyme inhibitors, and there are drugs with minimal or no effect. Therefore, when you're dealing with a patient in the ICU, it is always good to try and think of drugs which have an absence of inducing or inhibiting properties. They are highly desirable as an anti-epileptic drug in the ICU. Phenytoin, you must remember, can inhibit the anticoagulant effect of warfarin. Therefore, if you have a patient with non-valvular atrial fibrillation and a stroke or a mild stroke, and in whom he has been on warfarin, please do not give phenytoin, because as long as you're giving phenytoin, the effect will be inhibited and you will have to increase the dose of warfarin. And if for any reason the phenytoin has been stopped, the warfarin levels will suddenly go up. Topiramate and oxcarbazepine, they are normally have no effect, but they significantly increase the metabolism of oral contraceptives, and therefore you are likely to have unwanted pregnancies if you have a young woman in whom you have started topiramate. Okay, the effect of these enzyme-inducing drugs on concurrent anti-epileptic activity. And this is usually for polypharmacy in refractory epilepsy. So please, if you can see, valproate, lamotrigine, topiramate, and oxcarbazepine decrease the effects of concomitantly administered anti-epileptic drugs, whereas levetiracetam and lacosamide do not change. Therefore, they are the safest drugs to use when you have to use 2 or more drugs for control of epilepsy. Now, commonly used inhibitors of the hepatic enzymes, and please look at the list of drugs. There are antibiotics, there are antifungal drugs, fluconazole, itraconazole, ketoconazole. There are other drugs. So, drugs used in HIV medicine, antiviral drugs, and you can see proton pump inhibitors. So they are inhibitors. So if you are giving concurrently anti-epileptic drugs which are metabolized by hepatic metabolism, you will suddenly find that on withdrawal of this drug, those drug levels go up and they become toxic levels. Right. The next is, what do you do when there is hepatic or renal insufficiency? Now, a general rule is that the first generation of anti-epileptic drugs are mainly metabolized by liver. Therefore, you have to be careful of using these drugs when there is hepatic insufficiency. But you can use them in normal standard doses when there is renal insufficiency. Gabapentin. If you are treating a patient with renal insufficiency who has burning feet due to diabetes, please avoid gabapentin or reduce the dose of gabapentin very severely, because gabapentin in the second generation of drugs is the only one which is 100% excreted by renal mechanisms. Topiramate, the third, is predominantly excreted by the renal 90% by renal excretion if it is used as a monotherapy. However, if it is used in conjunction with a hepatic enzyme inducer, topiramate is about 70% excreted by the renal and 30% excreted by hepatic metabolism. So these are the other drugs. So you have to be careful with gabapentin, you have to be careful with topiramate when you're dealing with a patient with renal insufficiency. Now let's go to the effect on body weight. Now this, all of you know that the gain in body weight is valproate, gabapentin, carbamazepine, tigabentin, and vigabatrin. Neutrals are lamotrigine, levetiracetam, phenytoin, and lacosamide. And weight loss is mainly with topiramate. Therefore, take a situation in which you have a pleasantly plump young lady who has juvenile myoclonic epilepsy. It would be difficult for you to use valproate, although that would be the first choice. But if the weight gain is not to her fancy, I think it may be better to switch over to lamotrigine or perhaps topiramate. Okay? And the last point that I'd like to say is drug-induced skin rash. Phenytoin, phenobarb, primidone, carbamazepine, oxcarbazepine, lamotrigine, and zonisamide, they have a high risk of inducing skin rash. Whereas valproate, topiramate, gabapentin, ticagrelor, and levetiracetam, low risk of developing drug rash. Now let me show you about phenytoin and about lamotrigine. This is a lady. She looks practically like a female with burns, but actually she's phenytoin-induced exfoliative dermatitis, Stevens-Johnson syndrome, which we treated at JJ Hospital. And you can look, we treated her in the burns ward with withdrawal, steroids, etc. But we had to manage and we had nightmares. I can remember her distinctly. And this is one of my patients who developed a convulsion while she was on a holiday, and she was admitted into a hospital where the physician gave her lamotrigine in a rapidly escalated dose. And then she developed this skin rash. The husband sent all these plates to me and asked for my advice actually in Australia. Okay, what should we do? And I said, this is lamotrigine induced rash. Please omit the lamotrigine and put her on to lacosamide if you have to. And I think she recovered uneventfully. So I think these are some of the common issues that I have faced in the treatment of epilepsy in my experience, and I've shared them with you. Thank you.
Excellent. Superb.
Fantastic. Also relevant.
Yes.
Yeah, Jimmy. Yeah.
In our day-to-day practice, this is, I mean, really excellent. Sir and Ashok's, brilliant.
Dr. Praveen Shah, you
Because
want to make
both
some
these
comments?
talks,
Yeah.
I think both these talks are not from the continuum.
Yeah, but they add so much to the way we practice epilepsy in India.
Praveena.
Dr. Praveen Shah, you want to make comments?
Very nicely done, Sarosh.
Thank you. Asad, or has he left?
It's probably left.
Gentlemen's time for lunch.
For refreshments.
Huh? No, I don't think that is true for Asad. It may be true for me, but not for Asad.
So I think today's Continuum was really very nice. With all the talks were so good. I think this way of doing it is certainly making it better. So the next one we'll have on 28th of March.
I think, Satish.
Yes.
What I feel is that we should send the recorded link to Steve Lewis.
Okay. Of this one we'll send. I think it was really very nice.
It would be really nice if they can see how we manage it.
Yeah.
Yeah, and see also the discussions that we have.
Yes.
Yeah.
And we are openly saying that's an American perspective. Please look at it from the Indian perspective, particularly Ashok's, I think he will appreciate it much more.
Yes, I think it's a very good idea.
And then we'll say, we are going to send you the report, but please have a look at our
recording. Yeah.
I think it's on, what is it on?
YouTube.
YouTube.
Yeah. So next will be 28th of March, topic multiple sclerosis. we will choose the speakers in this, and Azad will coordinate. So please fill up your forms. Yeah.
Amazing. The last
Sorry?
is NMO and MOG. Second chapter is differential diagnosis and diagnosis.
Yeah. No, we will select it
NMO
quietly
and
after
MOG
this.
is the last chapter. We'll select them.
Yeah. So
I will take the NMO and MOG.
Very tough. Fantastically done.
Because I tell you, I was asked to write a editorial commentary for the annals.
Okay.
So I've acquired a lot of data. So give me an enthusiastic Azad.
Yes, sir.
Yeah.
Give me an enthusiastic postgraduate student.
Okay.
Don't leave the choice to me, but.
Okay, so we will go over the topics in a week's time. We'll finalize them.
Fine.
So March 28th.
I've already given you one topic.
Yeah.
Fantastic.
The next 3 should be reaching me by end of next week.
Oh, good.
The next 3. Yeah. Great. So thanks everyone. Fantastic session. Thank all the speakers, all the mentors.
Now the participants' maximum number on this was 17. That is essentially
That's the faculty.
presenter.
Yeah.
This is the faculty.
So Rahul, how many?
Sir, we have 20. Sir, we have 25 participants in our viewer link.
Okay.
And I think 5 or 6 from Gujarat. What I can see from that.
All right. And what about your YouTube?
Sir, YouTube we don't have much. I think it is 20 plus viewers.
So we are reaching about 40.
Yes, sir. Yes, sir. Yes, sir.
Which is a good number.
Yes, sir.
So just send us the list, please.
Yeah, sir. I will send along with that today's screenshot, that pictures of speakers.
Yeah, you've taken them all. No?
Yeah. I taken all. Yeah, sir. Yeah.
Okay. Great. So with that, shall we close?
YouTube, we have around 10 participants on YouTube. Yeah.
Thank you very much.
Thank you.
Bye-bye.
Thank you, everyone.
Fantastic
Fantastic
session. We must
session.
also find out how many people are viewing the YouTube later on.
Yeah, that is possible. Yes, sir. Yeah.
Okay.
Yes, sir.
So that also becomes as participants.
Yeah.
But not non-formed.
Yeah.
And currently we are sending to only institutes only. So
From next time, we will have a more organized
correct, sir.
approach